session or background check. Just to let everyone know, we have some icons on the Teams. It might be on your top bar or depending on where it is, but mostly it tends to appear on the top bar of your screen. And there are different icons, but there is a one that's a chat function. I can see most people have started using the chat function. So you can use the chat function to drop messages, to interact with your colleagues. I know it might be difficult sometimes to on your video. It might affect the internet. So if you are unable to on your video, or if you don't want to, or if you want to contribute and you can't unmute your mic, but please use the chat function. I would strongly encourage at some point we will have some conversation or interactions. It will be nice to hear your voice, your perspective, and your experience in your local context, because that is what will shape the training today. Okay? We want to share what is best available out there, reflect on what we are doing, and see if there is changes that we will do going forward with regards to our practice. If any of your colleagues have make any comments that you agree with, or you probably also disagree, or you want to make suggestions, you will. There is a function that says react with people's face. All you need to do is just click on the react. There is a like button to show that you agree with it. There is a heart button, shows you liked with it. There is a clap if you want to give somebody a round of applause. And if you feel well, if we are at some point, whatever it is, their contribution, or if something is really funny, you can laugh. And then a lot of them, all the emojis are there. If you want to also contribute, by all means, you can try to unmute your mic, but also if there are a lot of people that speaks at the same time, we probably wouldn't be able to listen to each other. But if there are a lot of people speaking, sometimes it's good to raise your hand. And once you raise your hand, I can be able to see, and hopefully I will be able to reach you. But by all means, you can just unmute your mic, and especially if I ask questions or invite you to have a conversation. We encourage engagement in today's session as well as next week. But if by all means your internet dropped off, that's fine. You can rejoin the session at a later day. Okay. So if your internet dropped off, I'm aware, please you do rejoin. We will have breaks in between throughout. We'll have a break just to stretch our legs or take our eyes off the screen. We'll have a big lunch break. And then we have another screen break, and then we hopefully round up around 6-ish p.m. It depends on how much we have in the rooms. We are expecting quite a few people. If depending on the numbers, we may break out in our groups. So at some point there will be breakout rooms. So the breakout rooms, you will automatically be assigned. You need to click in and join your room. In your room, we will expect you to have interactions with your colleagues, and hopefully at that time you should be able to unmute your mic and then share your thoughts with them. If you are allocated in groups or breakout rooms, depending on the number today, I will expect you to come back and share your conversation with the rest of the class. Okay, and before I continue, just before I start, I would really appreciate if everyone use the chat function now. All I want you to do is put in your name in the chat function and tell us which location you are joining, and also your sort of area of practice, broadly speaking. Are you in elderly care, MSK, neuro? So just put it in the chat function where you are joining. I don't think you need to put your name because we have the teams will record your name. So just put out where you are joining us from and your broad area of interest as a physiotherapist. So just put in chat function and say hi, and then add a bit of conversation of where you're joining us from. Good morning to those that are joining. Good morning, Quila, who joins from Gombe, my Oga from Gombe. Thank you. Still waiting. Can we use the chat function? Just drop the chat function where you're joining and your broad area of interest. Good morning, Enoch, from Lagos and sports. Um, okay. Good morning, Abdulhamid, from Gombe, Neuro. Yep. Good morning, Nashiba from Gombe. Good morning, Holly MSK, Ocho. Okay. Delta Orthopedic. Okay. Lagos Sports. Okay. Morning. Okay. That's good. We have quite a broad representation, predominantly Gombe, Jos, and Lagos. Okay, morning. Okay. While people keep on putting their chat or conversation, I will carry it on and provide the outline for today. So, the whole idea for today is we'll start. I probably will invite you to share your expectations for the module in terms of what you intend to get out of it today. We'll have a good overview of manual handling, patient handling, therapeutic patient handling. We'll talk about what are the professional and legal framework with respects to this generally, and specifically, hopefully, we'll look at Nigerian context. We'll look at how we can apply those concepts in our practice, and there will be some case studies for us to think through. And then we'll provide a summary at the end and close. And like I said in the beginning, there is breaks in between. I'm not going to read through this, but the whole idea is hopefully, like I said in the beginning, is to have an overall understanding of what is the global best practices with regards to therapeutic handling, manual handling, and patient handling, and contextualize that within our settings or the setting you are practicing. For us to achieve that, we will look at some basic biomechanical principles. We'll talk about the legislation governing those globally, if there is any. We'll look at specifically what we call risk assessments in terms of when you are handling your patients, both dynamic as well as the paperwork or the static one, and see if it's something you can apply it in your clinic. And we will start to look at common handling equipment that we use in daily care. Particularly, we will look at those ones in patient scenarios. And at the end, we'll try to reflect on our practices and propose solutions for possibly safe handling in low resource settings. So to begin with, thank you for those that have engaged and put in their location. For those that are joining us, we just asked if you can just put in your name, your location, and sort of your broad area of interest. But also, what do you want to achieve today? No need to unmute yourself. Just put in the chat box as well. What do you think you want to achieve today? Like I said in the beginning, today is Saturday. A lot of people could have been somewhere else, be it in the one base, or be it in your farms, or be it with your family, or you choose to be here today. Let's make the day worthwhile. So what do you want to achieve today? If you've not thought about it before now, it's just a thought-provoking question for you to think, what do you really want to achieve today? Okay. And you can drop your thoughts in the chat function if you have any. If you don't have, that's fine. Just for you to reflect and think, what do you want to achieve today? My focus today is to help you start thinking about handling, manual handling, therapeutic handling, or patient handling, but predominantly therapeutic handling in your patients, in your practice, and incorporate it in your rehabilitation plan or in your daily plan. So let's begin. Manual handling. Thank you for somebody who has dropped their thoughts in the chat function. It covers, it's a broad term that I think some of us have come across it or not, but it's a broad term that talks about the movements of anything. That talks about movements of loads, handling tasks like lifting, pushing, pulling, carrying, which I believe it's a day-to-day activities we do. Okay, well, we don't know whether it's manual handling, but I think all of us are engaged in manual handling in one form or the other. But in this context, the primary focus is in raising awareness of our ergonomics and seeing how we can reduce the risks for us who are handling those day-to-day tasks, or who are handling the patients or equipments. It is not only applicable to healthcare manual handling. Most industries, it is standard practice that most industry will have some sort of manual handling activities, including training for their staffs. However, in healthcare, it is also applicable in health and social care, where we deal with patients. But not only patients, we deal with also other equipment in the hospital. So manual handling, considered as a broad term, which involves movements of equipment, including loads, equipment, as well as patient. For patient handling, which is quite very specific, is a broad term, but it refers to any activity involving the movement, repositioning, or transfer of our patients. And in hospitals, it may include, it depends on where you're practicing, lifting those patients, turning those patients, repositioning them in bed, transferring them from bed to chair, assisting them with mobility. And the primary focus in this context is the safety, I think, for primarily, well, both primarily for your patient and the staff, trying to prevent injury during those movements, because there is no point in you trying to move patient or repositioning them when it is going to cause more harm to them or to yourself. And patient handling is a core task in health and social care. I would say these are bread and butter, which we tend to do predominantly for inpatient rehab settings and things like that, rather than outpatients, depending on the type of patient you see. When your patients are more able, they're less likely for you to lay your hands. However, manual handling goes beyond hand layings. It also involves some of the techniques you use, whether you use your hands or not. And if done incorrectly, it can cause staff injuries, which a lot of it, or can create patient discomforts or injury to the patient as well. And then the last part, which we'll be making reference to throughout the day, therapeutic handling in physiotherapy. It's more or less the skilled hands-on techniques you use to assist the patient in their movement and posture during rehabilitation, while ensuring safety for both the patient as well as yourself. And in terms of therapeutic handling, why is different from manual handling, patient handling, is because it goes a little bit further. It combines your clinical reasoning as a clinician, okay? And clinical reasoning, broadly speaking, we are talking about the processes at which you arrived at a decision, covering your assessments of the patient, but also your knowledge of ergonomics, okay, on how to position yourself as well as your patient, which that's where the parts of the manual handling comes in, and the therapeutic facilitation. So by therapeutic facilitation, I mean you have a goal to improve the patient, to optimize their function and independence. So for therapeutic handling, it's that clinical reasoning, your knowledge of ergonomics, and then the goal at which you are doing that activity. The handling itself is part of therapy. In therapeutic handling, yes, it might be that you're trying to reposition the patient, but sometimes as therapists, when we're handling patients, hopefully we should also be thinking of how we can improve the function of the patient or promote their independence, not only making them passive in terms of transferring them from one place to the other. Unlike patient handling, which focus primarily on safety and comfort, a therapeutic handling will aims to promote recovery, independence, and how you promote recovery. It's how you activate the muscles, enabling them to take part in the rehabilitation process, which we'll be talking about throughout the day. But promote also their independence, so trying for them to do things by themselves, and functional movement. And here, in terms of therapeutic handling, I would say it is our bread and butter, or supposed to be our bread and butter as therapists. Okay? Because we, among all healthcare profession, we are the predominant ones that tends to use our hands a lot, or try to understand the purpose of movement in patient, whether we use our hands or not, but we facilitate that based on our knowledge of the profession. So just to check in terms of, I know it's early to do this, but I'll probably say before, because it's always good to have a look at it. So we have tax one, which is the lifting medical supplies, and that is include pushing a hospital bed or using a hoist for patient transfer or pushing a hospital bed. Looking at tax one, where will you categorize it? Are you considering, is it manual handling? Is it patient handling, or is it therapeutic handling? And then looking at tax two, transferring patient from bed to chair, or, or helping patient to stand, or moving patient in bed. Where will you categorize it? Is it manual handling, patient handling, or therapeutic handling? And then looking at the last one, sit to stand facilitation for stroke rehabilitation, or get mobility for stroke activation, or get training with therapeutic use. Is it manual handling, patient handling, or therapeutic handling? Can you put in your responses? Thank you. I can see some people have started putting their responses in the chat. So looking at those three, can you let me know which one is it? What is A? What is B? And what is C? So I can see one response on the chat already. Thank you. Okay, thank you, A. Thank you, Quila. Okay, therapeutic handling. Okay, thank you, Idris. That's good. From the three responses, just to confirm, I'm really pleased. That's good for those that have replied. Now, on injury risks, I guess it can be assumed that due to our knowledge of biomechanics and the mechanism of the spinal injury, I would say, and our ability to treat patients, maybe, I didn't know, but I will ask, maybe we are less likely to suffer musculoskeletal injury. That is probably might be the assumptions, either from people outside, or maybe we will feel like we are immune in terms of musculoskeletal injuries or injuries during our movement because we are the expert. But I guess the evidence shows otherwise. Our perception of the training and knowledge may lead us to believe that we are immune, okay? Or to a certain extent, I would say we probably might be blinded with the need for us to hustle in code, trying to work hard, trying to, especially when you're young, trying to make some money. And it is only once when an episode or injury occurs that we may start to think and reflect about our own personal safety. Okay. And this situation, that episode that happened, may be compounded by lack of risk assessment undertaken. And when I'm talking of risk assessment, I'm talking of not only your own responsibility as the physiotherapist to protect yourself. So we'll talk about the patient handling, but we are looking at also ourselves. So your own risk assessment to protect yourself from injury, especially that we will be doing this activity for a very long time, but also risk assessment from your employer to identify the activities you are doing and how they can protect their staffs from this injury. Now, I'm raising this conversation because it is also, we are the main advocate or front runners of risk assessment, occupational health, or risk injury, both either at an organizational level or on our own personal level when we are seeing those patients. So there is that employer responsibility, there is your own responsibility. So and this is also a thought question for you. What factors do you think contribute to MSK injury at work? What factors do you think contributes to MSK injury or injury really? Because sometimes some of the injury goes beyond MSK injury. Or what factors do you think contributes to MSK injury at work? If you don't mind, I would like you to put the information on the chat box. And depending on the response, I may ask you to also share it with the rest of the group. Okay, poor ergonomics. Okay. Poor ergonomics, thank you. Poor handling. Okay. Thank you. Poor handling. Poor posture. Thank you. Okay. Thank you. Poor physical, psychological, lack of proper knowledge and ergonomics understanding. Okay. Inadequate working tools. Yeah, I like that, Aquila. Inadequate working tools. Okay. Yes. So that's a good overview of responses. Now, there is a survey that was done here in the UK, and I certainly believe there is also a lot of studies in Nigeria, which the same resonates with what has been done in UK. Now, among physiotherapists, one of the top list, if they are asked to, now we can have evidence of patient and things like that. But one of the top things is the fact that there is the repetition of an action. Okay. So doing things over and over again, it exposes one to the likelihood of having that MSK injury. So the repetition of an action. So think that of doing an activity over and over again for the next 20 years. That's a lot. Think of doing an activity over and over. So sometimes it's not just the fact that you are trying to help the patient at that point in time, but it's the accumulation of those activities over your lifetime that might impact you in terms of the injury that you expose yourself. Okay. So repetition of action. And I believe you guys are expert on when you're seeing your patient, you tend to refer to them, oh, repetitive strain, repetitive injury, repetitive injury, repetitive injury. We are also not immune. Working in the same position comes second, but that might be different from your own locality for a long period of time. treating large number of patients in one day. I think this will resonate with you working in your own clinics in Nigeria. Bending or twisting your back in an awkward way. Bending or twisting your back in an awkward way. I guess the question will be, oh, are we not supposed to bend? Are we not supposed to twist? We will look at those ones as we go along today. There are better ways which we can avoid bending and twisting our back. Lifting or transferring dependent patients. So patients who are unable to use their muscles or able to engage actively, and instead of us to resort to other methods or use of equipment like Quila mentioned, we ended up deciding to pull them or push them. I guess this may be probably familiar practice, but this is a risk to you as a therapist. However, I will also say that this is a risk to your patient relatives, okay, whereby we allowed or encourage patient relatives to be pulling, pushing, which without knowledge. So we may have knowledge, but them without knowledge. But under our supervision, we encourage that to happen, or even our rehab assistants allow them to be pushing, pulling, twisting. Now, lack of equipment, yes, can make us to do that, but there are other methods that we can encourage the patients to actively engage in the process rather than us pulling or pushing them. And sometimes when we are injured, we don't look after ourselves, or we continue to do it because we want to help, which is good. But again, we have to look after ourselves. And then reaching or walking away from your body, which another point which we will discuss as we go along. Oh, are we not supposed to reach? How far away are we talking about? So the mechanics at which you reach out or you move persons also will influence, will exposes you to the risk of the injury. So what in particular, I will make specific reference that the last point is about generally our risk exposure, both as therapists in our day-to-day therapeutic handling, but also our patient relatives or people that are under us as therapists, because we are responsible for that, their plan of care. In specific, with regards to the therapeutic patient handling, therapeutic patient, I believe it's critical in our rehabilitation. And in healthcare, it goes beyond simply moving the patient. So we are not just interested in, oh, moving the patient. Can you send them to, can you transfer them from A to B, or can you, it uses the movement as a clinical intervention. And I want you to start thinking of it today, that you don't have to sit in your office and then you start treating the patient. You don't have to ask the patient relatives to move the patient from point A to B to start your clinical interventions. You can do your intervention by encouraging that movements, engaging the patients in those movements as part of your therapy. Whether they are rolling in bed to sit at the edge of the bed, whether they are rolling from side to side for their personal care, whether they are rolling out of bed or trying to get them out of bed, or whether they are trying to stand, because all those can be part of your rehabilitation, encouraging them as you go along. And as therapists, the responsibility of how you shape your practice lies within your, it's more or less within your scope of practice, how you shape your practice. Yes, there may be some limitations of equipment, like was highlighted earlier, but still there are things that you can think of doing or implementing in your settings without even much of equipment. Hopefully we'll look at some examples as we go along. And why is that important? Because it promotes functional recovery. Okay, it promotes functional recovery. The handling techniques, it will encourage your patients to actively participate in the process and thereby gaining it, helping them as they move, patients to helping them to regain their strength, okay, So there is that goal of when they are moving, what exactly muscles are you trying to activate, depending on their problem list or what they are deficient. It might help them to regain their balance, maybe when they are standing, instead of you all grabbing them and hugging them or trying to see how you can challenge their balance. Or when they are walking, the amount of support you give them might be different. It might help them improve their coordination. A typical example is when they are sitting to standing, which will help the way you position them as well as facilitates their sitting to stand, will activate their leg muscles and improve their weight bearing. So you don't have to put them in a parallel bar, them standing, for you to start doing weight bearing exercises with them. But those transfers that you're doing along the way can be a clinical intervention. It can support neuroplasticity, so neural changes in summary. So our brain is malleable and adaptive to change, but there are different neuroplasticity. But what we're looking at is the purposeful movement that stimulates the nervous system to relearn the motor patterns that they may have lost or they may have forgotten. Okay, uh, and what drives that is the repetition. The underlying factor or anything, the underlying key word in neurorehabilitation or neuroplasticity is the repetition. And isn't even beyond, it's not only in neurology, even in MSK, even in whatever shape. So when somebody is learning a skill, either post surgery or whatever it is, their ability to repeat that action over and over again enables them to learn those skills that you want them to do, and they can be able to do it effortlessly as they go on. So the same thing when you're thinking of moving a patient, handling your patient, broadly speaking, it's how you guide them through those processes. Think of it as a rehabilitation, rather than just transferring patients from one point A to B. It prevents learned dependency. If we do it for them, they will learn to depend on us. If their relatives do it for them, they are more likely to step back and allow their relatives to carry it on and do it for them. So as much as possible, encourage patients themselves so that it will reduce the reliance on the caregivers and possibly even on your rehab assistants. And that's what we call active participation or active rehab. So instead of lifting the patient passively, I want you next time when you're thinking of removing the patient after your assessment and everything, so that's where your clinical reasoning comes in. Help them, use cues to help them initiate the movement. Okay? Use cues to help them initiate the movement. And by cues, I mean even the verbal prompts you will give them can make a difference. Or the tactile prompt whereby you touch them. Okay? The tactile prompt depending on where you want to move, can help them. Or the auditory prompt or auditory cueing, the rhythm for certain patient, it can help them to initiate that movement. And like we talked about, it's your handling can enhance safety and reduce the risk of injury. Yeah? Your handling, it reduces so proper therapeutic manual handling, it will minimize the risk of falls as well as the MSK injuries we've talked about. So what we've discussed or highlighted earlier on is exposure to yourself. But once you are encouraging the patient to be an active participant, they are less likely to depend or to be more passive as you during your rehabilitation processes. So it's good for both you as the staff, whether you the therapist or your rehabilitation team, as well as it's good for the patient for you to consider that the processes they are going through you enable them to sort of help them take over. Yes, I think somebody has raised their hand. Is it Mohammed Kabir? Maybe it's a mistake. Mohammed, is it, if it's a mistake, that's fine. You can bring your hand down. And it improves patient confidence and engagement. I will 100% tell you this in my patient handling. Improvement, patient confidence sometimes is not about the ability of the patient. It is possible your patient have the ability to transfer from sitting to standing. It is possible your patient has the ability to stand. But it is their confidence that has been knocked off, especially the elderly patient, that you have to figure out when you are handling them. They will be fearful, yes. They will try to grab things. They will try to hold you. They will try to not to shout in terms of they will need support or family. But you need to figure out, based from your clinical reason, how you can support them to transit from that passivity to being active in their rehabilitation, to give them that reassurance that you are with them in a safe space and reduce the amount of support you are giving them in their rehabilitation. Because they will never get out, especially patients who have fear of falling or who have history of falls and they've fallen before. It will just be a cascade of events where they will remain in that cycle. So for you to break that cycle, you need to step away, allow them to take active part in their rehabilitation. And one of the underlying, well, if there is one thing I always also look for is the engagement of the patient determines the success of your rehabilitation. First, how I look at it is you see this patient for 1 hour, 30 minutes, 45 minutes, 2 hours. The rest of the time in their rehabilitation, they spend it with what? So for them to be able to spend it in their rehabilitation outside your clinic, outside your engagement with them, you have to empower them. They have to engage with you, and then they can be able to carry on those activities as they moved away. So it builds trust. When you engage them, it builds trust and motivate them. And I would, if it's not something you're thinking, I think whenever you're seeing a patient, what I will encourage is think of what they will carry on doing without you, without anybody really. What will they be doing on their own? And everything, it integrates clinical reasoning. So every handling decision, so that every handling decision is based on an assessment that you've carried. And when I'm talking about assessment as a therapist, I'm talking about both the subjective and the objective. So when you go to see your patients, you will have a chat with them, and then they will tell you their problems. You will confirm in your objective. Uh, you will confirm in your objective on objective assessment on how what they've said, and then thinking of the goals you want to achieve from your, so from that goals you can now, it will inform how you will go ahead in terms of supporting them in their rehabilitation. So integrating your clinical reasoning into your handling or patient handling, that is what defines your therapeutic handling. And as a therapist, it comes with practice, but as a therapist, one of our bread and butter, and I think the skill sets that you probably should look for or develop is your ability to integrate all the things the patient is saying your into your clinical decision and produce an individualized care uh, that will enable the patient to respond and engage with you. Um, so yeah, I think that, so these are the probably things that I feel these are important in terms of therapeutic handling or patient handling. I will jump over. I think somebody asked a question. Before I move on to my next slide, which is the legal framework, I will pause here and ask if there is any question. So yes, if there is any question, please drop them in the chat box and I will try to respond as soon as possible. And if also you want to speak or you want to comment, by all means, you can unmute yourself now. We're going to move to the next slide or next phase of the training. So Mohammed asked that, yes, Mohammed, you can unmute yourself.
Okay. Good morning, sir.
Yeah,
Good
morning.
morning.
Yes.
Thank you for the content-rich lecture. Sir, could you please shed more light on how therapeutic patient handling supports neuroplasticity? Thank you.
Okay. Yeah. So neuroplasticity, just start. So neuroplasticity, just talking about that, I won't be able to expand broadly on neural plasticity because it's a session on its own. But think of the brain, okay, as it's malleable, okay. So malleability means it changes, it adapts to the information or the whatever we put into it. So if the brain changes and the changes of the brain is what allows a child, so a child that was born or a children that are growing up, to learn things as they go along because the brain develop and changes. But as an adult or as a patient, sometimes our brain can lose that ability to move or do whatever it is, probably due to injury. So when there is an assault or trauma to the brain, usually the brain has different parts that controls different activities. So that part will lose. We will lose that ability to do those to do it. Or maybe when your patient is lying on bed for a long period of time and they can forget or they can have this whatever ability they have can can be suppressed and they tend to forget how to do certain things. So how your handling, so how you support them in terms of the ability to remember or to relearn. Okay, so to relearn means to remember those things they've forgotten, is by enabling them to do those things over and over again. So repetition, the first one, the first key principle of neuroplasticity is repetition. Repetition, ability for them to do over and over again. Now, as a therapist, when you are enabling them to rehabilitating your patient, there are different phases of enabling a patient to remember in terms of neural changes. There is the initial phase, or what they call associate phase, whereby they try to form the idea, the broad idea of the pattern of movement. So think of a child who has never walked, or maybe an adult who has forgotten how to do things. For them to redo it again, you don't expect them to start a child. Let's maybe go back to a child. You don't expect a child to start running from the beginning, or you don't expect an adult who maybe his hobby is, who maybe understands how to, let's talk bed mobility. You don't expect an adult who maybe has lost the ability to move on bed to roll from lying supine to sidelining, or lying supine to sitting at the end of the edge of the bed immediately. So the initial phase or the associated phase is trying to facilitate them to remember that pattern of movement of rolling. And how you do that now in your handling is, at the initial phase, you give them a lot of feedback. That feedback can be your hands, you supporting them with your hands. There are different time points at which you will put their hands. For example, the pelvis and pelvic girdle and the shoulder girdle. How you do that is verbal cue. You encouraging them to, first of all, try to roll on your side in terms of getting out of bed. How you do that is also trying to enable them to bend their legs and then use their legs to roll to the side, which is an activity we'll do it later on. Now, as they are doing that, you have to, as they are strength progresses, as their memory tries to remember those patterns, you try to reduce the amount of support. So the handling you do give them initially will be more. So it's expected that at the initial phase of people trying to learn things, you have to reduce the amount of feedback. And feedback can be both verbally, hands, and everything you give them, and then you reduce it as you go along. Reducing it, I will allow them to engage their muscles. Reducing it will allow them to think through the problem. So you move from the associative phase or the initial phase to the intermediate phase, whereby they try to solve the problem themselves. So think of it as them trying to solve the problem themselves and then trying to form their own pattern of movement. And then from there, then you move to the expert or independent phase, whereby they can be able to do it on their own. But in terms of the handling, now it's the therapeutic handling driving neural plastic changes is feedback. That's the amount of feedback you've given to them. Practice, the opportunity you've given to them to do it over and over again. So when you support them, reduce the amount of support you give them as their effort progresses. So in summary, the two things you should probably go and read about is feedback, the amount of feedback, and then practice. These are the two key things that defines neural plasticity. Yes, Vera. Your hand is up unless if it's a legacy hand. Yes, Vera.
All right. Thank you very much. Can you hear me?
Yes, we can hear you.
Okay. Please, I have a question. In a situation whereby you are trying to lift a dependent patient,
Yes,
and you find out that you can't really do it by yourself and you need assistance from maybe the relative, and the
yes,
person tells you that it's not their duty, it's not their job. In such
yes.
situation, what will you do?
Excellent question. Vera, can you please, I encourage you, can you take that question and we will repeat it again when we come to the. So this is one of the key things I will be discussing what we will do. I think that is one of the purpose of today's session. So it's in my afternoon conversation. Okay. So
Okay.
this one is just a background. I think we will have a conversation around your question. Please bring that question back. And if I forget, just in case. Okay.
All right. All right. Thank
Yeah.
you, sir.
Yeah. And that is common practice. What will you do? All right. So in terms of handling, there is professional and legal framework or requirement for us to handle. So to do manual handling, to do therapeutic manual handling. I'm not, I guess in Nigeria less so, but in other part of the world, when it is a requirement, it's not an option, it's a must for you to consider therapeutic handling. It is our obligation to consider that. And it's expected of us to do that. And if you don't do otherwise, there are consequences for us in certain jurisdiction. While there is no single global law dedicated, okay, into solely for practice or manual handling, I figure I went through the literature. I couldn't see one single universal law. But what I can see is that the legislation falls into three different categories, three different main categories. And I will encourage you to consider it in your own practice, whether there is one in Nigeria or not, but the regulation falls into three different categories. One is the professional regulation and the scope of practice, which authorizes us or limit us in what type of manual handling we will do or not. And in Nigerian context, this MRCB, there are those professional body that enable us to have those professional registration, and they stipulate our scope of practice and what we can do or not do. Then the second one is the safety practice handling laws, where they focused on preventing injuries for both the healthcare workers, that is you, but also for your patient and things like that. So they emphasizes on risk assessment and injury. The last one rather is the occupational health. So the second one is the safety handling risks, laws that focus on preventing injuries to healthcare workers. And then the last one is the occupational health and safety one that emphasizes on assessment, risk assessment, and injury prevention. As physiotherapists, I think all the three falls within their domain, our domain, and I will expect us to be looking at those things, or I will encourage us to be looking at these things in our day-to-day practice. These laws are meant to ensure patient safety. I believe the only reason why we see patient is not we see patient not only reason not to cause harm to them, but to promote their recovery, but also to ensure that they are safe. And like the question Vera asked in terms of what do you do, because you will be put in a situation and you don't want to cause more harm to the patient. So these laws are framework that enables us to consider patient safety, but also the laws also talks about professional competence. If you are not competent enough to figure out what to do in a situation, or you don't have the skill sets to carry out a handling technique, then that is where the law comes in. The professional registration. It is expected that as a therapist, or it depends on the jurisdiction, you should have sufficient training either during your undergraduate training or post-registration training to carry out that. But even if you are not a therapist, usually workplaces usually have manual handling trainers, experts, occupational health advisors, reviewers who help in reviewing those workplace ergonomics to make sure that it follows international best practices. And international best practices requires that therapeutic handling complies with those laws while integrating your clinical reasoning and rehabilitation goals. So on one hand, you are a therapist, all you are thinking is you want to improve the patient, but on the other hand, you have to think of all the handling that you're doing to make sure it complies with what is required. And we look at those laws, which varies from jurisdiction to jurisdiction. And like I said, there is no unified standard international law, but the common themes, okay, the common thread among all laws. So it doesn't matter whether you're in Nigeria, whether in the UK, whether in the US, the common themes across those professional and legal frameworks is one, there is that mandatory registration. Now, the mandatory registration is for you as a therapist who, by the virtue of your registration, is competent, qualified enough, have the requisite knowledge to deliver that manual handling task. Okay? Of course, if it falls outside your scope of practice, you are expected not to do it or to seek for help or training. So these are one of the expectation, professional expectation. There is also a theme of risk assessment. Risk assessments is when you are seeing that patient, you have to figure out what are the risks, both to your patient and to yourself. And the law also covers risk assessment on organizations. Now, it might be that in certain climes, organizations might not be responsible for their own role of providing either the equipment, like earlier mentioned, or providing the training, which is another common theme that was featured. But my conversation today, and hopefully by the end of today, is take ownership of how you do things going forward. Okay? Because it's not the benefit is not only to your patient, but to yourself. But also it will be to but it's good also to be for your patient. Okay, so take ownership of how you do things going forward in terms of assessing the risks when you are moving your patients, assessing the risks when you are asking your rehab assistants or caregivers to help with patient movement, because it will go a long way in your rehab. And if you are in private practice, it will speak well in terms of your client. I believe trust you will have a very good feedback. And the last one is the use of device or equipment where possible. Now, it is where possible that you will use equipment. And I said where possible because for me as a rehab, my approach will be to encourage patients to activate their muscles, to do it themselves, because equipment takes away that ability for patients to do it themselves. So first is to encourage a patient to do it themselves using different strategies, their body mechanics, and then secondly, to use equipment depending on the assistance they need. Now, if they need just minimal or moderate assistance, which we'll look at later on, I will step in as a therapist, and this is where my handling comes in. I put in my support, my feedback to them. But if they need more assistance, I'm not expected to pull patients, to drag patients, to use my muscle strength, because if I do this for a long period of time, I will be out of business. So I will need to start thinking about equipment. I will need to start thinking about equipment. And that equipment, yes, is the responsibility of your employer. But in the case where the employer doesn't provide equipment, what are the alternatives? Okay, advocacy, and trying to find other ways that you can move the patient. And yes, like I said, in the UK, we've talked about it. In the UK, it's more or less this. The regulator is the Healthcare Profession Councils, and they made it absolutely clear that physiotherapists owe a duty of care to one, their patients, two, their colleagues, three, to your employer. And this includes treating patients involving manual handling. So, and it's not only about you doing it, but also delegation of treatment. So when you're asking somebody to do things, make it clear in terms of what you want them to do, how you want them to do it. And the provision of guidance, manual handling guidance, advice, and education, because those people you are asking them to do, they may not know how to do it. And it's one of the activities we'll do also later on in terms of the guidance you can develop in your own context going forward. I guess the question I will ask is, are you aware of any law or requirements in your locality or jurisdiction or in terms of manual handling, therapeutic handling? I will open the floor. Is anybody aware of any laws or requirements, or are you aware of laws, requirements, or things? What are the things you are doing in terms of manual handling, therapeutic handling within your settings, or manual handling generally, equipment use, handling techniques, and things like that? No? Okay. Probably I will crack on there. Okay. Akache Shuruma Ansani. Silence is golden. So in Nigeria, I guess what I would say is it is the MRCB and NSP, but probably there is no specific dedicated national guideline solely for therapeutic handling. It might be a standalone document. Some of those principles, we have them. They may be integrated in the broader MRTB Professional Code of Ethics, which you can go back and read. I believe there are broader MRTB Professional Code of Ethics and there are also standard of practice informed by global physiotherapy standards. But the health and safety legislations mainly provides framework that a physiotherapist, through the process of handling manual handling, risk assessment and risk management, they can minimize any risks to their patients, to themselves, as well as to make sure that whatever they are delivering to the patient doesn't cause more harm. And one of those things, it includes us going through our clinical reasoning, documenting the processes of how we arrived at that particular process or procedure that we are doing for the patient. And in my next slide, there is I'm not sure whether you can see it clearly, there is a bit of comparison between UK and Nigeria in terms of broad areas. So In terms of the laws available for handling, in the UK, there is what they called the manual handling operations, and it is binding. I couldn't find one in Nigeria, but it's something, like I said, we can take responsibility and ownership of care to the patient. And there are a lot of legal status documents that look at expectations from therapists. And when you breach those in certain climes or jurisdictions, patient can take you to court. You are liable. In Nigeria, it's mainly civil or administrative, whereby your employers or Labor Act talks about the employer providing those provisions of equipment. And there is also a health policy that is produced in 2020, but that is non-statutory, means it's not necessarily binding, it's highly recommended. And there is a clear, explicit risk assessment processes or procedure. And the summary of Regulation 5 of the one of the regulations here in the UK is that first and foremost is you avoid doing things that will put you into harm. So if you're going to involve in manual handling specifically, try to avoid it. So encourage the patient to engage with their muscles in the context of healthcare. But in the context of if it is not your patient, do you need to move the object? Do you need to move the equipment? If yes, the answer is yes, then you assess the risks. What is the risk involved, both to yourself, to the patient? And once you identify the risks as the hazards, you find ways to reduce the risks. And reduction of the risks includes using your handling techniques, using the equipment if that is needed, and if there is need for training, you train. You train both yourself or the staff that are under you. In Nigeria, there are no specific contexts, but outside today, after today, I would like you to adapt this approach in your context, whereby there is no need for you to move things. There is no need for you to move a patient if they can do it themselves. Encourage the patient to do it themselves. If they can't do it, you need to think of assessing the risks to the patient, to yourself. And once you assess them, you figure out how to reduce that risk. And if you are delegating or working with other healthcare professionals, train them, show them what are the better options. Now, equipment requirement is one of the main things I believe that was highlighted. In other climes, yes, it is a requirement that of course, the money is always a problem, but as far as reasonably possible, when you ask somebody to do an activity, manual handling, or do a job, then you are expected to provide them the necessary tools. So that's one part on the responsibility of the employer. Then on your own part, it's expectation for you to use the equipment. So there is that provisions of the equipment from the employer. Then there is that the expectation from you as an employer to use those equipment. In Nigeria, maybe it's loosely defined, like I said, but there are several equipments that is available, and I will go through those equipments in my session later on. The plan is going forward, figure out how you can use those equipments if they are available in your settings. If they are not, advocate for those pieces of equipment where possible. If you are in private practice, think of putting those equipment in place because they will definitely make a difference in your practice. Now, the training requirements, thank you all for coming today. So training requirement is expected for both during your training as well as when you graduated. In other climes, jurisdictions, it's non-negotiable for you to attend trainings depending on the work you are doing. Yes, you have a broad experience of as a physiotherapist, therapist, but also specifically manual handling training. There is that mandatory expectation for you to attend the training. And yes, so we tend to, as I'm one of those trainers specifically on manual handling, where we train both our students before they graduate as well as therapists in terms of handling specifically. But therapeutic handling, which is also a next level of manual handling, is your clinical reasoning, your expertise, your experience, where you applied different principles to see how you promote functional recovery for your patient. It may not be a requirement in your context, but I will encourage you going forward, try to upskill yourself and in terms of those training provisions, and upskill your staffs if you are a clinical lead or person who is in charge of a unit, or upskill your assistants. And it falls under, in terms of, like we talked about, the professional scope of regulation, the HCPC and CSP. Why are we doing that? There is an evidence of the impact of implementing manual handling on one part, but as well as therapeutic handling to your patients. A study was done covering in the UK. When I look at the data for over a couple of decades, when those laws are implemented across the healthcare, there is a reduction, 35% reduction of injury related to all those musculoskeletal injuries. Not that it's eliminated. You can never ever eliminate risks. You can never ever eliminate risks, but you do whatever is practicably possible to reduce it. And that is the plan. Do whatever is practicably or reasonably to reduce the risks. Now, in Nigeria, now those data, there are data out there. A study that was done by Professor Agera Adekoke in 2008 mentioned as high as 91%. This may vary. But the emphasis is there is direct correlation between strong legislation and lower injury risks. Now, you may not have those legislation within your jurisdiction, but what I will encourage is think of applying those evidence in your context where you applied handling techniques or manual handling, therapeutic handling to minimize injury within your settings. I will quickly go through some of those laws just to give us an insight on what are they and how they applied, and maybe think of how you can apply it in your context. Now, these laws are this is just manual handling laws. They are not for therapeutic handling, but as a therapist, you incorporate it within your overall activity. One is the employee's duties. So you as the employee, you need to take reasonable care of yourself and others. I think it's good. It makes sense, a lot of sense for us to look after ourselves. So that's one of the expectations. It's common sense. Sometimes those laws, they say, is common sense. It's looking after yourself, but it's not only looking after yourself, it's looking after the people that you are working with. Because tomorrow, if they are not there, you are stuck with those workload. And then work with your employer to follow the risk assessment that is put in place for your own safety, and not to intentionally or recklessly interfere with or misuse any provided health and safety equipment. There may be several safety equipment in your settings. Is a question of how it's being used. So there is a requirement in other jurisdiction for you to make sure that you abide by those bits. And like I said, in essence, some of those things are just common sense. And it means just use equipment for the intended purposes. And if there are no equipment, trying to use the best, least intrusive way. And it's also expected. So in terms of identifying what is the manual handling tax, now is the question of whether you are competent enough to train. So there is that employer and employee responsibility. So identifying the manual handling tasks with significant potential for injury. When you are about to do those activity, what is the risk level? Is it a high risk that it can be cause injury? Is it the moderate risk? Is it the low risk? If it is whatever the level of risk, remember one of the first principles of manual handling generally is, can the task be avoided? But if you are looking at it in the context of therapy for a patient, I would say, can the patient do it themselves instead of you doing it for them? So that's where your clinical reason as a therapist come in. In manual handling context is, can the task be avoided? In the therapeutic context is, can the patient do it themselves? That would be the first question I will ask. If it cannot be avoided, then in manual handling context is, can it be mechanized? And by mechanized is using any pieces of equipment to help you in moving, any pieces of equipment in helping you in moving. It can be as funny as moving the boxes in your office using a trolley, basically. But in the patient context, it's about, instead of you pulling the patients, is using a piece of equipment that enables the patient to move, plus their own effort. So you just add that piece of equipment or prompt or verbal feedback and then enable them to move plus their own effort. And if not, sometimes it's expected that we conduct risk assessment to reduce the risk to the lowest reasonable practical, to the lowest level before carrying out that task. Now, there are two parts which we'll look at. There is a paperwork risk assessment, which I think it's been done even in Nigeria. But my emphasis today will be on what we call dynamic risk assessment. You as therapist on your feet, a patient is right there in front of you. What will you do? Is quickly thinking, identifying the risks, lowering the risks, and carrying out your tasks. And there are frameworks or processes that we'll consider that will help us to do that. And then it is expected that your employers will support you in doing those sort of you as an employee will follow the system and processes coming that has been set in place to minimize the risks. So to summarize or to put this in context is, as an employer, we're using the traffic light system is those that are employed you, but it might not apply because it depends on the context and the laws, is where possible, avoid all hazardous manual handling. I would say it in your own context, with or without the employer being supportive, is the question of, if you are doing a task, the first question is, can you avoid doing that task? If it is unavoidable, you assess. If it is unavoidable, you assess the situation. And yes, it doesn't have to be a paperwork tick boxes. As a therapist, there are processes you can do to assess the situation. And after you're assessing the situation, you now proceed in taking action to reduce the risks, as we discussed previously. Now, risks are not static, and so also your assessment. Whether you do a paperwork assessment or your employer asks you to do it, or your employer do as paperwork assessment, it will change. When you assess the patient today, maybe later in the evening, the things will change. So risks are not static. So also our assessment should be dynamic. And sometimes it's not about our sub notes where we sit down, we take the record and do from start to finish. No, it's about when we engage in those handling techniques with the patient, is thinking about what to do at that point in time. In addition to that paperwork, that the full assessment that we'll do. Then there is a law also. This particular law, and I will link it to what we will be looking at later on, is specifically about lifting operations and lifting equipment. So all mechanized equipment that helps in lifting a patient from point A to point B, there is a law that requires there is a law that governs that. In your patient context or therapeutic patient context, while this law may not be applied, but what I want you to consider in your context is the safety checks that is provided in this law, or the things that needs to be considered when you are moving your patient, depending on if you have the equipment. And specifically, it applies to the use of hoist or hoisting patient. We will look at that also later on. What does use of hoist or hoisting patients mean? There are specific documentation that is expected to complete when you are hoisting, but also as a therapist, when you see those patients or when you're going to use the hoist, there is a responsibility on you to do quick risk assessment, or to look at all those things that are likely to cause harm to the patient. And you are expected to minimize it or eliminate the risks where possible, or minimize it if not. And then there is one more law that we'll consider. One is the use of provisions. So provisions of equipment and the use of the equipment. And this covers all manual handling equipment. That does not include hoist. So that does not include the equipment that was covered by Lola. So Lola, the last law, covers pieces of equipment that deals with lifting patients up. This particular one covers all other equipment that does not involve lifting patients up. So moving on to things that we will hopefully, so just the last few slides is just to lay the background of things that we'll be looking at: the law governing it, professional framework, legal framework, general definition or terms of concept. Some of the terms also to look at in manual handling specifically is there are terms, so line of gravity, looking at the image, the red line, so there is a dot probably just below the navel of the person standing. So the red line from that particular dot all the way going down is the line of gravity, and it is an imaginary line. So the dot is what I call the center, what we call the center of gravity. So it's an imaginary line from the center of gravity to the ground or the surface the object is standing on. And that line of gravity defines the direction at which the force of gravity is acting. So we all know gravity pulls us down, but at the point at which it's acting, from this anatomical position, is straight from that center of gravity all the way down, which falls within the base of supports of the participant or the person, the model. The center of gravity, which is the point just below the navel of the person in the picture, is the point where the mass of the body is concentrated. So hypothetically, if you take it, is the point at which all the forces of gravity appears to act. If you tilt the patient, if you ask the patients to balance themselves around the center of gravity, it's expected that they will stay balanced, irrespective of the position they assume. If they sort of balance themselves around that point, because that is the center at which the gravity tends to revolve. It does not need to lie within the physical bounds of the object or the person. So that is an imaginary dot. That center of gravity can fall outside the person, depending on the position they assumed. So let's talk in relation to the line of gravity. LOG stands for line of gravity. BOS stands for base of support. COG stands for center of gravity. And by base of support, I mean all the points at which the individual is in contact with the floor. So the location of line of gravity in relation to the base of support, it has a huge influence on our balance and stability. Now, in the anatomical position, which I shared in my previous slides, but also in the picture just below the sports models, the line of gravity is between the legs and the feet under the person. So between the 2 feet of the person. And I believe as we all agree that this is very stable because it's expected that once the line of gravity falls outside the base of support, then the stability of the person is affected. The closer the line of gravity is to the center of the base of support, the better the person is in this position. So what it means is from the standing, the line of gravity, when you're sitting down, your line of gravity is closer to your base of support. So sitting down is more stable than standing, and lying down is more stable than sitting down, which is common sense. But again, that is the explanation of it. Now, if the line of gravity falls outside the base of support, like in the model, the sports model or at the top, so there is a line, red line drawn all the way down. The person holding the ball, now that is the center of gravity just around one of the hip joint. Now, if the line of gravity falls outside the base of support, now the base of support this time around, the line falls outside, not between the feet. The person must provide corrective muscle action, usually movement, otherwise they fall. And at this point, the muscles are really working hard to counteract or balance the displacement of the line of gravity outside the base of support. Now, shorter line of gravity between the center of gravity and the ground provides better balance, which is what we talk about. So these are 3 concepts. I will be making reference to it later on. And then we'll talk about levers. I think we are familiar with levers, but so there are 3 types of levers, which I'm not going to talk about it. That's not the focus of today. But the summary is our joints, they are the fulcrum or the point at which the movement occurs. Our muscles are the effort or the muscular force applied. And then the load, the weight we've been moved. And in manual handling, the weights can be both animate and inanimate objects. It can be bed, boxes, or it can be animate objects. It can be your patient. They are the weight or the load that you are moving. Now, the implication of it that we want to talk about is later on is longer lever arm. So by longer lever arm means you are holding the object away from the body. It will increases the strain on you. Okay, moving objects away from the body will increase the strain on you. So in manual handling context, one of the main principle of dynamic handling is trying to bring the object closer to you. So instead of holding a box, so let me see if we can see. Let's see if I can. So this is a cup of tea. So this is a cup. Okay, let's see. Yep. So this is a cup. So if in manual handling context, instead of you moving the cup, let's say the cup is okay. So this is the cup. Instead of moving the cup far away from you, instead of you moving the cup far away from you with an extended elbow, try to reduce the elbow and pick the cup from a shortened lever. So the lever can simply be shortened when you are moving and handling a patient by shortening the lever, by moving the object as close as possible to yourself. And how you move the object as close as possible to yourself before you move the object is reducing the lever, your hands, or moving closer to the patient, moving closer to the patient. And it will reduce the amount of effort that you applied when moving an object. So think of your patients. When you are trying to move a patient, or your therapists are trying to, your assistants, rehabilitations, or patient relatives are trying to move a patient, one of the things as a therapist you can encourage them is, instead of pulling or moving from a far distance, they try to move and close the distance to reduce the lever. That first principle will enable them to reduce the risk of injury if they are using their hands around their shoulder joint. The second implication is use larger joints and muscles rather than relying on your arms alone or even your back muscles. Use larger joints and muscles rather than relying on your arms and back muscles. How you do that is, when you want to move an object, instead of bending all the way, trying to squat, bend down from your hips and knees. Engage your hips and knees. They are the big group of muscles. And then you stand up from that. For your patients, it can be, instead of pulling your patients all the way up, is trying to squat, go all the way down. Use your knees, move, create a dynamic base of support and help your patient. In other places where you have the resources, instead of bending or pulling, there is what we call profiling bed. There are beds, especially, I think maybe some familiar is what we call ICU beds. So encourage the patient relative, encourage your rehab assistant to increase the height of the bed so that it is at your waist level. So you don't need to even bend or squat. You can just pick the object from that height and transfer and use it. Avoid awkward postures because awkward posture increases the risk of injury or musculoskeletal injury. What do I mean by awkward posture? Our spine is generally in a neutral position. I'm not expecting you to stand in a nice straight line. Just take the natural spinal posture when you are moving. Try not to bend excessively. Try not to twist, because twisting increases the risk of injury. It's an awkward posture when you are twisting and then applying a load. So when you twist and when you are applying the load, the strain is more compared to when you're just taking your natural spinal posture. Let's look at it in transfers. And we will, the first one is sit to stand. The first one is sit to stand. Now with sit to stand, think of patients leaning forward. When a patient leans forward, what does it do? And what is the implication on your transfers? Think of, so COG means center of gravity. So my first point is in sit to stand. Let's look at sit to stand and applying those principles in sit to stand. Asking your patient to lean forward, what does it do? How does it help in you in transferring? Anybody wants to comment? Please, this one I would probably appreciate if anybody unmute, anybody if is aware can unmute your mic and make a contribution. So when you are asking the patient to stand up, so the first is asking them to lean forward. Why do we ask them to lean forward, or what do you think is the implication in relation to their center of gravity?
It reduces the distance between the center of gravity and the line of gravity.
Okay, it reduces the distance between center of gravity and the line of gravity. Okay, Yes, it does, but the reduction of the distance increases the base of support. But yes, it does. I agree with you. But why? Well, that probably is the secondary thought. But why primarily we ask patient to lean forward, so bring their head forward. Yes. Anybody wants to contribute? You can put it in chat if you. Yep. Carry on.
It also shifts the line of gravity away from the center of the base of support.
Yes. And what does it do when it shifted it away from the base of support? When it's displaced forward, what does it do?
Yeah, it reduces the load on the muscles of the thigh, so that you give them the ability to stand.
Yes. So yes, thank you. So I put the comment about leaning forward. So first is, instead of just teaching your patient to displace their center of gravity forwards, we talked about, because you want them to stand, automatically displacing it forward, it reduces the load on their normal standing, but it encourages them, it gives them that prompting whereby it makes it easier for them to come forward. It makes it easier for them to come forward. We'll look at that later on in the afternoon. So that's one of the principles. Yes, why we encourage stability, but sometimes you can use it in your rehabilitation to promote a good handling technique or good manual handling technique. Simply by displacing the center of gravity forwards makes the person's easier to stand up, because at this time he is less stable and then there is that tendency feeling like he's want to fall forward, and then you encourage the person to stand. The second one is the therapist widens their stance, the base of support. Why do we ask? So now is the patient, now is you as the therapist. Why are you expected? Why do we encourage you to increase your base of support? And what do we mean by increasing the base of support? Anybody, please.
Sir, to minimize the risks of our own workplace.
Okay. Yes. How do you minimize the risk? So what is the implication? So first of all, is when we say widen
if a
your
therapist
stance.
widen his base of support,
Yes.
he is incorporating all his own muscles of the thigh, that is the quadriceps and the hamstring and the core muscles, so that he can help the patient to stand. So, rather than using only his arm and back muscles.
Okay. Thank you. Partly, yes, I would say it. Anybody wants to add on that? There are
I think,
yes.
hello. I
Yeah, I
think
can
by
hear you.
widening the base of support of the
Yes.
therapist will be stable. So in
Yes.
case there is need for assistance in terms
Yeah.
of when the patient wants to fall, you already have you are stable. You can be able to offer that assistance.
Excellent. Yes. So I think that's the primary reason. So yes, I agree with you, Umar, but I think what Rabi mentioned is the primary reason. So first is you widen your stance, your base of support. By widening your base of support, we talked about in our last previous slide, it increased your stability. The patient is not stable. He has already been displaced forward. He's at the transition of moving. So he has tendency of losing his balance. If the patient loses his balance, you don't want your patient to fall. So you have to be at guard, at ready to make sure that you are supporting him in that transition from sitting to standing by making sure you are stable. Widen your stance is basically by your legs feet instead of feet together. At that stage, you are stable. Not necessarily, of course, when the patient is displaced, then you can be able to react and things like that. So that's the main reason why the therapist is encouraged to widen their stance. The next one is the therapist keeps the patient close. Why do we encourage the therapist to keep the patient close when you are moving them from sitting to standing? Anybody, please?
It reduces strain on the therapist.
Okay. Yes, it reduces strain on the therapist. So we talked about, thank you, Vera. We talked about levers in the previous slide. We talked about levers. So when you are moving, always think of using a short lever arm where possible. The longer the lever, the more strain you will injure yourself. Shorten the lever, move close to your patient as much as possible. Use the bed, increase the bed height, find a way of shortening the lever. So keep close to the patient. And once you have this, it will be smooth transition, supporting the patient from sitting up to standing. And hopefully in the afternoon session, I can be able to, maybe if I can't demonstrate it remotely or not, possibly. The next one is, and thank you for those that contributed. The next one is bed mobility. We will talk about slide sheets. I'm not sure how much is it that we are aware of, but when you are doing bed mobility, we tend to use slide sheet to resist friction, but that's not the main point because we've not discussed it today. We will discuss it later. The second point is what I want to raise. You try to maintain neutral spine while guiding the movement. Okay, you try to maintain neutral spine while guiding the movement, and you move along with the patient. Another thing that, yeah, you try to maintain neutral spine, both in terms of the sit to stand practice as well as bed mobility. I will encourage also we add what they call dynamic base of support. We'll talk about that later, dynamic base of support. And by dynamic base of support means that you might need to move your legs. So if you plant your legs on the floor and you are moving the patient, you might you stand the risk of twisting or turning. But when you have a dynamic base of support, you will use your legs and move the legs around, or you try to use your knees and hips, whereby you can lower yourself down or increase your height, trying to manage the transfers or movement. And when you're using, particularly when you're using the pivot transfers, you're rotating using your feet. So instead of planting your feet, try to move your legs to avoid twisting, keeping patient close and guiding the movement smoothly. So yes, thank you. Thank you all for those that contributed. Does anybody have any questions so far? I know I've been talking for almost 2 hours. I would like to pause here. Anybody have any questions so far? I know we have one question that we'll answer later on. Anybody have any pending question? Okay, if there is no question, I think we'll just take a quick screen break, I call it. This is now time is different. I guess in Nigeria, this is almost 11 o'clock. So can we come back by 10:47? So can we come back in the next 15 minutes or 30 minutes? Let's come back by 11 o'clock, please. So let's go for a screen break and come back by 11 o'clock. Yes. All right. Good morning and welcome back. I believe it's 10 o'clock. Just to make sure that I'm not speaking to myself, can you please drop me just a hi hello in the chat box to make sure that you are back? Just to make sure I'm not speaking to myself. Really. So if you are back, can you please drop me a chat function? Thank you. Keep dropping them. Keep dropping the chat. Thank you. So we'll wait just 2 more minutes before we start. Okay, welcome back. So thank you for those that have dropped the chat function. I think we will start. Hopefully the rest can join. Because I'm mindful we started with about I see 32 participants. Okay. So before we go on a break, I just have a look at the chat function. The Mohammed mentioned about short people having more balance than the tall people, and Enoch have answered it already. Yes, because earlier on we talked about the principles whereby if the line the shorter the line of gravity or the closer it is from the base of support, the more stable the person is, and the higher the less stable the person is. And you can think of that when you're doing starting to provide stability for yourself or stability for your patient. Moving on. So we'll be talking about, which we probably have discussed, what I called the principles of efficient handling and movement. Okay, the principles of efficient handling and movement. Now, with moving and handling, the first thing is we probably need to plan ahead and assess the tasks, the environment before you begin. Assess the tasks and the environment before you begin. Check the loads, the stability, the weight. If you can, I know it's not everywhere you can figure out the weight, but apart from even checking the weight, it's not only whether the weight is being, how you check the weight is not whether the weight is being written on the box, but also you can check it physically by looking at it or just pushing it, trying to see if it's something you can lift. The stability, trying to make sure that the object you are trying to move is stable. So if it's a box, things that moved all over the places, they have tendency of increasing the risk of injury or you to fall. But think of your patient. There is what we call impulsivity in patient rehabilitation. Impulsivity means the patients can behave out of order. So the patient might just decide to do things that will put both you and the patient at risk. So you need to think of how stable also your patient is, or your patients are when you are assessing them. And this will come in your assessment. Because if a patient is not stable, then you need to figure out how to manage the risks when you're doing it. Ensure your path is clear of obstruction where you're going. And use mechanical advantage or use mechanical aid rather. Screen not visible. Okay. Thank you for the feedback. Screen not visible. Let me stop and start again. Not sure why is screen not visible. Let's stop and start again. Oh.
So I think it's from his end because we can see the screen earlier.
Okay, all right, thank you, Abi. So let's continue then. So if it's not okay, it's visible. Thank you. Screen not visible. Even NSP saying it's not visible. So can you please, if it's not visible, I've restarted. Can I confirm that it's visible now? Yeah, can
Yes, it
NSP.
is, sir.
Okay, it is. Yes, it is. Okay, NSP is in. Okay, good. All right, brilliant. Thank you. Yeah, let's continue. So thank you. So in terms of plan ahead, maintain a stable base and good posture. We talked about base stability and how you maintain a stable base. We said is by increasing the base of support. Okay, we've discussed this before the break. Stable base by increasing the base of support, widening your stance, so opening your legs together. So put your legs feet apart. That's you, the person that is moving. But also think of your patient. When you are moving them, think of their base of support, reducing their risk by putting their feet apart. Usually, we recommend patients, we tell them to put their feet shoulder width apart. Shoulder width apart. That is the standard practice where to enable them in stability if they are just standing or if they are sitting from sitting to standing. Maintain a good posture. We said neutral alignments before we go on a break. We said neutral alignment. Maintain a neutral alignment. Now, looking at the picture on the screen, certainly one with it's a good posture, one is not. Believe you me, even myself, I probably been found wanting in doing the one that is not a good alignment. Uh, but with the awareness, I'm more conscious of my posture when I'm leaving objects. I'm more conscious of my posture when I'm moving a patient. We talked about bending our knees and hips. So the picture with the good mark, green good marks, is the one that demonstrates how you can bend your hips and knee. So instead of you bending from your back, you just lower yourself down from your hips and knees to pick the object. You lower yourself down from your hips and knees to pick the object. Our back muscles are not designed to carry big load. The likes of the erector spinae, all the multifidus. Our back muscles are not designed to carry load, but because of convenience, we tend to bend our knees, or our patient tends to family caregivers tends to bend their back, and this is why most of the times, I guess, one of the common MSK injury you'll find is back pain or lower back pain, because imagine you doing this type of bending, the one on the picture with the red cross mark, over and over again over a period of time. Even if you are just lifting a light object, it will gather over a period of time. And sometimes when you lift, when your back is vulnerable, and when you lift an object with certain level of weight, your back will just snap. So going forward, just as an awareness, when you want to lift an object, be it your patient or not, try to go using your feet, bend from your hips and knees. If you can't, if you don't have hip and knee injuries or pains in your hip and legs, alternative way is try to lift the object from a height, comfortable height, so you can, instead of it lifting it from the floor, you can start from a higher position. The other principle we discussed before we go on a break is moving the object close to your body. Moving the object close to your body. Now, if I want to lift an object, looking at the green tick, you can see the person is not lifting the object far away. His shoulder is not stretched in front of him. He brings it close to the person's body, and then you lift it as close as possible. If the object is on the floor or on the bed, all you need to do is you move closer, dynamic base of support, either by lifting your legs and moving closer to the object, or by shifting your body. And once you grab it, bring it close to your body, shorten the lever to reduce the strain on you. Also, as a good practice going forward, think of shortening the lever when you are moving. Think of educating your patient, your therapist, your colleagues, the patient caregivers when you want to encourage them, shortening the lever when they are moving objects, when they are moving the patient, when they are moving the beds, when they are all sort of activities they are doing. Correct secured handhold. Now, when you lift the object, you need to try to hold it. Apart from keeping it close to your body, make sure you get a firm grip to ensure that you secure the object. It can be using the handles or not, but try to prevent the load from slipping or shifting away from your body when you are moving. In terms of your patient, when you are moving a patient, maybe let's say for walking, when you are facilitating walking on a patient, it's important you secured your patient, and we'll look at examples of where you will put your hands to make sure that your patient is well supported without unnecessarily preventing him from moving or activating his muscles when they are moving. So correct secured handholds. And we said try to have a dynamic base of supports to avoid twisting. So lower the load in a smooth, steady motion without any jerky movement in terms of lowering it. So looking at the picture, not the one on top, the lady, you can see how she's dropping the object. One, there is a long lever, which is likely to cause strain. Two, she's bending from the back. She could have gone all the way in terms of the squatting from the other picture at the top, or she can put the object from a higher and at a higher position. In terms of twisting and bending is when you are moving, when you are changing direction, instead of you doing a turn. So I think we are probably, myself, I've been found wanting in this sort of things. So when you pick an object and you just twist, turn, and then go to the other direction, avoid that. Move your feet, move your body around instead of turning to protect your spine. Know your limits. Know your limits. Only lift object that you are comfortable with. There is no need for us to be superheroes. It's a long journey for us as a career, but also for our patients. Some patients are heavy. There is no need to ask for people that are strong, heavy built men to start pulling. And this is where the equipment comes in place. If a patient's load is too heavy, or maybe the patient doesn't have enough muscular strength that can activate their movements in bed or transferring them from one place to the other, use equipment, know your limits, because I don't think you want to continue over and over trying to pull the patient, push the patient, and different types of patient. There are guidelines, like I said earlier on, in different jurisdictions. However, if those guidelines doesn't exist in Nigeria or in your own context, but it's good practice to consider those guidelines and apply it in your setting, because I think the guidelines, the laws are meant to safeguard you, the patient, and the employer. There is no need. It makes sense for you to apply the evidence in your own practice, even if your employer or the setting doesn't necessarily support that. In terms of knowing your limits, there are weight requirements that is being provided. It's a normative value. It's available out there. Usually, it's expected that at each and every level, there are different weights that you can carry. There is difference between, now is based on evidence, not necessarily differentiating gender, but it is demonstrated that male can carry more weight over female gender. And then secondly, depending the level at which you are carrying the weight, the heaviest weight should be lifted around your waist level because it minimizes the strain and the force, rotational force around the spine. Loads at the shoulder and near the floor are much lighter, especially when we talk about if the weight is far from you, the lesser the weight you can carry. The closer to you, the more weight you can carry. Like we talked about lever arms. The shorter the arm, the better for you. Because longer arm increases the risk of injury. Awkward posture increases the risk of injury. The next picture after the ones the people standing is in sitting position. Now, if you noticed, the weights are smaller in sitting position, and it's because the body cannot create a dynamic base of support to distribute the weight. The legs are fixed and cannot adjust to stabilize the weight, and that's why it's recommended if you are in a fixed position, less weight. So when you are moving, try to create a dynamic posture when you are doing movement and handling or therapeutic handling. The trunk and pelvis in the picture below have limited ability to shift the weight or maintain their balance. And this restriction means that it translates to lower lifting capacity from the picture compared to standing positions. And we talked about the difference between the male and the female, and these are all normative value. Now, I want you to spot the difference on the picture, on the slide. And I want you to think, thinking back to what we discussed earlier, just after this break, in terms of efficient moving and handling. Although the picture doesn't speak about which one is better more explicitly, but my aim is trying to demonstrate correct and incorrect posture, on which one is better and why. So the question is, how often do we emulate this type of posture? So different between this posture. I'll probably open the platform now and ask colleagues to contribute. Between the two posture, just summarizing everything we discussed. Talking about correct and incorrect posture, lifting object, let's say inanimate object from the floor, or moving your patient. Which one is the correct lifting technique, or supposedly to be a correct lifting technique, and why? And the next one is, how often do we use this in practice? How often? How often? Anybody wants to comment on what do you think, which one is the correct lifting posture and why? And how often do you think we use it in practice? The floor is open. You can put your comment in the chat box just to check that we are following the conversation. I know we've discussed it. Just to summarize, anybody wants to give us which one is correct lifting technique and why, and how often do we use it in practice? Yes.
Good afternoon.
Morning.
Morning, sorry. My name is Mike Gideon. Yeah. I just want to give an attempt.
Yep.
To the question. So thank you, Mr. Presenter, for bringing this up to us. So I think the right lifting technique for me, the one on the left, even though the picture as you highlighted has been justice, but I think the description is clear. It needs to be straight, and lifting needs to come from your knees, where you push up. That's because it's strain on your back, and the risk of causing any back pain, acute back pain. And regarding how often we use it in the clinic, I don't have such data, but from an observation, I don't think we really do this a lot. Yeah.
So when you
I
say
think
we don't
after
do,
this
we don't do the correct or incorrect one, which one?
correct, we don't really observe the correct
Okay.
lifting tech in terms of our handling in most clinics that I've seen. And I think that is the benefit. That is the things that we should take back from this lecture. It's not as if we don't know them; it's just that we don't use them often. We
Yeah.
don't. We don't. During inductions, when we're inducting new colleagues into the, we don't really train them on this handling. We should have posters. We should have. We should watch colleagues when they handle. I think that we need to do more of the training, but I think that's the purpose of this. I think these are the things we take back to our clinics. Yeah, I think.
Yeah. Thank you, Mike. Anybody wants to add from what Mike have said? Very good contribution.
Good afternoon for the presentation.
Yep.
Actually, from my understanding from the picture, none is the correct lifting posture.
Okay.
Because if you look at the previous pictures you presented,
Yeah.
Both the picture at the right and at the left,
Yeah.
they are of the same. They assume the same position.
Yes.
But then, if you look at the previous one, the back is straight and the lot is closer to the body.
Yep.
The previous, yes, the one with the green
On top.
goods.
Yeah.
Yeah. So if you look at it critically, it
Yeah.
differs from the last two that you asked question on. So to my understanding, none of them is correct.
Yeah.
From the picture.
Yeah. So the question is, what is the correct posture, Rabiu? What is the expectation, the correct expectation?
The correct expectation is that the back should be straight, the lower limbs should bend at the knee, then the lot should be closer to the body.
Okay. Yeah. Thank you. I think there are 3 points you highlighted. Short lever, the object should meet close. Lower limb bends at the hips and knee. However, the conversation is the natural spine, neutral spine, not necessarily straight. Yes, it can be straight, but neutral spine. Yeah. Yes. So neutral spine. And yes, you are right in terms of the picture. But as Mike have said, it is assumed there might be the picture is not the correct depiction of what we expect to do. And yes, Anthony, do you want to talk?
No.
Okay. Rabi, is it you that you want to jump in? Okay. So continue. Let me continue. So in terms of the picture, as Mike have said, the two picture, whilst they don't depict the correct posture, but the expectation is on the picture on the top, where the load should be from the lower limbs, the neutral spine, and the object should move close to you. Now, the second bit is how often do we do it in practice? Like I said, I am culpable, but now with the knowledge, I tend to avoid it. We tend to take the shorter, easy bits at that time and solve the problem, but it doesn't solve the problem in the long term. It creates problem in the long term. And I want to encourage you, and I think that was also what Mike has highlighted, is going forward, try to raise the consciousness of that and try to observe your surrounding. You will see a lot of this. But again, because we are here in this training and we are responsible for our practice, think of how you can implement or encourage the correct posture by either the conversation of pictures of correct manual handling techniques, or in your induction. We tend to do induction or not. It depends on your setting. But certainly, I know when you have students, either as intern or corpus, or even new staff, or even ourselves, we can have CPD workshops, in-house training. We can raise the conversation of the proper handling techniques that we can do in our practice. Yes, thank you. So moving on, we'll be talking about risk assessment. So we said that in manual handling, the first principle is avoid. If you can avoid doing the task, avoid it. If you cannot avoid it, then you proceed to assessing the risks that is available on that context. And there are different ways we can do the risk assessment, but just so that we go through some terms, there is a hazard. So when we are talking about risk assessment, there is what is called hazard. And hazard is anything with the potential to cause harm. And that hazard does not generate harm, but it's just the likelihood that it may, the possibility that it might cause harm. Okay? The possibility that harm will occur. And then there is the risk, the likelihood of the event of the harm occurring or happening, and it can be categorized into severity. Earlier on, sometimes you can use traffic lights, so you can categorize risks into low, medium, or moderate and high. And depending on how you categorize those risks, and that's what sort of plan you will come up to either minimize, reduce the risks in your own settings. Like I said, it is probably difficult or impossible to eliminate all risks. However, the aim is to minimize them as much as possible. And the question is, what do you think could be a hazard when completing moving and handling? So what are the possible hazards or potential risks or things that we might call risks? So when you're doing moving your patient, when you're doing moving and handling from the image we've looked at, what are the likely things that could go wrong? What are the likely things that you think might go wrong? I'll also open the floor. You can put your comment in the chat or you can unmute yourself. So when you're doing any moving and handling, what are the likely things that could go wrong? Falls? Yep. Yep. The person can fall. That's a big one. Falls, yes. And then risks of injury. Anything else? Yes, it depends on the age. Yeah, I can see Mike typing. Yep. I can see Ibrahim. Depends on the age of the patient. Okay. Sleep. Yep. The weight of the patient. That's interesting. Soft tissue injury. So what is the weight? It depends on the age. It depends on the weight of the patient. Okay. So these are thought-provoking comment because the age and the weight, I guess this is what you need to factor in your risk assessment and decide on things to do. But these are good feedback. Yes. Doing it for a long period of time. Okay. Okay. Yep. Musculoskeletal injury. Okay. So all what you've added, I agree with them totally. Okay. The likely things that could go wrong, I agree with them totally. So these are sort of examples, and by all means, my example is not exhaustive. These are just example of what could possibly go wrong. Now, example of hazard is when we are having a poor posture or incorrect techniques, bending in our waist can increase the risk, instead of bending, can increase the risk of back injury. Somebody have mentioned slip discs. Heavy, so the hazard is also, people talk about depending on the weight of the patient. Now, heavy or loads, it's a hazard for us to be drawing or lifting heavy weight loads, especially when we hold it far away from our body. We talked about this earlier on. So sometimes it's not the load only, but how we handle the load. Holding it far away from our body, it increases the risk of injury. Slippery or uneven surfaces, we talked about falls. So sometimes the falls happened because we did not identify the hazards. The falls happen because we do not address the hazards. So slippery or uneven floors, risks of falls or slips. And I will tell you examples of why I said sometimes it's the hazards, identification of the hazards, prevention of the hazard, removing that hazards. That's where your risk assessment comes in, might prevent the fall. So I had a patient in the community many years back, a couple of years back, over 5 years or so. We usually go out for a walk. So one of the goals, one of the sessions is taking out the patient into the community to go to our GP, to go to our pharmacy to pick up medications and things like that. So we practice walking, going out. The patient has some memory problems, but she's cognitively sound and can be able to engage. She has some visual problems, so she problem with her visions, and she's waiting for an optician, trying to see an ophthalmologist. But I'm focusing mainly on the physio part of it, talking about hazards and things like that. So we went out one of those fateful days. We went out for a walk, and maybe I will ask you what happened. So we went out for a walk, and then when we come back inside, immediately when you come back inside, the patient, now she has a particular place she sits, and along that path of where she sits, I dropped my bag just close to the chair, okay? On going out is not a problem, but when we are coming in, the patient now trips. The bag that I dropped on the floor, close to the sitting sofa, the patient trips on it, and she did not fall, but she sort of staggers and almost fall, and then she used to support herself from the couch, and then she sits down. Now, there is a hazard there, and the obvious bit is the hazard is the bag that I dropped on the floor. There are other issues going on, but the main thing is if I have identified that particular bit, so objects on the floor, pathway of the patient needs to be removed or taken away. If not, the patient had the risk, that will increase the risk or likelihood of the patient falling. But that is not all in terms of my assessment, looking back in that patient. Now, if it is a patient, normal person without all those bits, the person might not be challenged by that tripping. But looking back, what I think also has contributed to that patient is one is when we go out, there is a bright sunlight, the place was well lit. Immediately when we are coming in, there's that change of lightening. And when you are doing your risk assessment, which we'll look at in my subsequent slide, environment matters in your assessment. So there is that change of lightening whereby it is possible the patient was not able to quickly pick up the back on the floor. Secondly, because there are also conditions that has to be within the patient whereby she has visual problems and maybe she couldn't see what is on the floor. Thirdly, of course, because we are coming in, her mind went straight up. She just want to sit down, and the focus is all through to go and sit down. And then at that point, she is at an increased risk of falls. And regarding my last point of the patient want to sit down, when you're handling a patient in your clinics or when you're supporting a patient, there are time points whereby the patient might be at increased risk of either falls or any or injury and things like that, because at that point their mind have been distracted or they are focusing on other things. For example, when you're seeing a patient at the maybe beginning of the rehab, if you're doing a, let's say, sit to stand practice or walking, by the time the patient is exhausted and you are moving closer to the chair, they are more likely, because their musculoskeletal system is exhausted, to be at a risk of injury or not to be able to withstand the external perturbation, because the system-wise, their endurance has reduced and they are all looking forward to sit down. So at that stage, as a therapist, my recommendation is always try to think throughout your rehabilitation at different time points to be alert in terms of how you support the patient. So at that point, I'm more likely to support a patient when we are returning back to sitting down after an activity, more likely to support the patient back to their resting position before I leave them. Or maybe when a patient is just about sitting on a chair, you just want to make sure that you support them back before, because at that point they are more likely to of injury or exposure to risks in terms of moving and handling. Moving on. So talking about the other one is faulty equipment or inappropriate equipment, unpredictability of patients, insufficient training. We talked about unpredictability of patients. Some patient can be impulsive, or unpredictability of equipment, handling equipment that are not secured. There is likelihood of it being displaced, and when you are moving it, it might cause a bit of injury. So in risk assessment, probably if I would summarize the steps that probably I will encourage for us to consider is the identify the risks or the hazards, identify the risks, look for anything that could cause harm during the task. So always look for anything that will cause harm during the task. Like I said earlier, the conversation is in two parts. One, there is the documented risk assessment, whereby we sit down, either your organization assess the risks, put the things in place, or you do your assessment as therapists to inform your decision making on how you manage the risks. But on your day-to-day practice, you probably will, especially when you're dealing with patients, you want to identify anything that could cause harm. And that could be the nature of your patient. Your patient is impulsive, unpredictable, so you need to be aware that at any point they can drastically change. Or it could be the load. I think Ibrahim mentioned about load, and a couple of people mentioned about load. The load of the patient, it is likely to cause harm, so you need to be aware of it. It could be the environment, like I mentioned in my own situation. The back on the floor, the lightning, it could be one of those things that could cause harm. So, and then identify who may be harmed in the process and how could harm occur to the patient. For example, falls, either to the patient or to the staff. For the staff is injury, for the patient also it can be injury as well, or discomforts if they've fallen. Evaluate the risks and decide on possible action or that you could do. And sometimes you can assess the likelihood of the event happening and the severity of the event happening. And you decide on the measures that you will do to reduce those risks. Okay. And that can be, maybe you are using a hoist, ask for assistance. And I think we will refer back to the question earlier on somebody asked. It can be ask for equipment, ask for assistance, or clear the obstacles. In my own situation, the example I've given is I should have cleared the obstacle on the pathway. And when you have a documented plan, for example, in the documented risk assessment is the question of you implementing it. and putting the measures in place if there is a formal risk assessment. But if there is none, it's just at that spot you try to figure out what to do and address the risks as you go along. Like I said, risks are not static, they are dynamic, they change with time. So also your assessment needs to change with time. Even if there are documented risk assessment in settings, they need to be updated regularly, they need to be reviewed. For your patients, they changes with time. So as a therapist, there is an expectation that every time we see our patient, we are constantly in the mood of sort of risk assessment. What could go wrong? What is it? What could go wrong? What is it? That will help us to identify those risks, minimize those risks to the patient without necessarily going into full-blown assessment. But while these are the steps, the first and number one cardinal thing is always avoid if you don't need to do. Like you said, then if you need to do, you assess the risks, you manage the risks, and then you identify the hazards and how you manage it is identify the hazard which helps you reduce the risks. And you can do that by using equipment, using training to minimize the risks. So in terms of risks assessment, like I said, it's dynamic, it's continuous, it's adaptive, it changes. But the main thing is ensuring safety for both you and the patient during every single moving activity, moving and handling activity. Even though in this situation, there will be no formal risk assessment, it may exist. I'm not sure. Maybe I will ask the question here. How many people in your organization, how many people tends to have a documented formal risk assessment? You can just drop the chat in the comment. If you are aware of or have you ever come across a documented risk assessment, or you as a therapist have ever carried out a documented risk assessment for your patient? Has anybody here is aware of or have ever carried out a documented risk assessment for a patient? So by risk assessment, I mean when the patient is admitted to the hospital, usually a physiotherapist, occupational therapist, nurses will review the patient and then decide on how to manage the patient, both in terms of moving them by rehab assistance or transferring them or walking them, sort of a plan that other members of the MDT team will follow. Anybody come across it or have anyone in their setting or have done one before? No? Okay. So even none exist at organizational level. Hopefully by the end of today, you might think of it. If you're in a private practice, it's easier for you to implement. If you are government settings, it might be something that you may think of it and plan it. But even if a formal document doesn't exist, I would encourage you to continue to look out for this dynamic risk assessment every single day when you go out to see your patient. Okay. So in terms of the quick dynamic risk assessment, there is an acronym highly recommended for us to consider when we are using that every single day. And the acronym is one is T, tile O, or tile, normal tile that we are aware of, or ELITH. Anybody can tell us what do they stand for or what do they mean and how do they apply it in risk assessment? So you can do this both in terms of the formal documentation, but you can also use this to help you think when you are seeing your patient or when you are handling equipment. And that will, yes, anybody know what this stands for? So quick dynamic stress assessment. So anybody know what tile O stands for and ELIF, and how does it applied in moving and handling or handling any object? You can put it in the chat box, but I think this one will benefit from you unmuting your mic if you want to contribute. Okay, Amos said no. Okay, or maybe he's typing. So what does it stand for? What does this acronym? No idea. Okay, thank you, Amos. Okay, maybe yeah, okay. So going forward, I will encourage you to use this tile. So they are both sort of the same. They stands for the same thing. It depends on what you really, initially it was tile, T-I-L-E, and then the addition of the O. And then there is also the term that is being used more recent, the ELITE, E-L-I-T-E. Now, the T stands for the tax. And the tax means that when you what is the tax that you are about to do? The tax means that what is the tax? The T stands for the tax. What is the tax you are about to do? Are you trying to move your patient from point A to point B? And as an example, or are you trying to move the patient bed from point A to point B? So what is the tax? The second, the I for the tile is the individual. The individual is referring to you as the therapist. The individual is referring to you as the therapist. It's talking about your individual capability. It's talking about what you can do as an individual. Patients of different loads, do you have the necessary muscular strength to move the patient, which is not what I will recommend. So do you have any injuries that will prevent you from carrying out the task? The L is the load, and the load can be animate or inanimate object. The L is the load. And by animate object, I mean your patients. So the patient in this context is considered as the load when you are moving them. The inanimate object is other equipment you use in the hospital when you are moving them. So the L is for the load. The E is for the environment. Remember earlier on, I was talking about how the environment has probably affected my patient to staggered. So the environment. How is the environment? Is the environment cluttered? Can you see where you're going? I appreciate we tend to work in a very busy environment, but we need to start to considering what is the risk to our patient if it doesn't serve the purpose. So what is the environment? Is there sufficient lighting? Is the path cleared? And the O is for others, which can stand for equipment for the tile. And the ELITH is sort of the same thing. One of the E is environment, the other E is, the first E is the environment, the last E can be equipment. And the L after the first E for the ELITH, it's for the load, which we said is the patient. And the T is for the tax or the technique. If you are looking at your as a therapist, the technique or the tax. So tile or ELITH, whichever one, I find it very good framework to rapidly think on my feet, or when you are developing a document of risk assessment, if you follow this TAL or ELITH, it will cover all the risk assessment or assessment that you may think of in your clinic or in your setting. And we'll talk about one of them at the time, and hopefully we'll apply them in our practice. We'll have an examples of how we apply them. Now, in the tax, we said, is it necessary? First principle of always moving and handling is, do you have to carry out the tax? And if you applied it to your patient, can the patient not use their muscles to do it? Can the patient not use their muscles to do it? Then the second one is, how often are you doing the tax? You need to think about it. How often are you doing the tax? How often are you doing the tax? If you're thinking of your patient, we said to drive neuroplasticity, it's important you create an environment where there is high level of repetition. So all you need to do is enabling the patient to do a particular task over and over again. Can the person help, or does it involve taking the full body? We talked about that's where the patient muscles come in. The task, where are you taking it? So the movement, are you taking it from point A to point B, from their bed to the gym, or from their bed to the outpatient department? Where are you taking the patient from point A to point B? What is the height difference? We talked about using your leg muscles to lower yourself down. Or we talked about lifting the bed if you have a profiling bed, so that you'll be able to help in terms of handling the to avoid straining your back muscles rather. Because if it involves stooping, twisting, turning, it's something you don't want to do it. So the tax, so you need to think about the tax. Are other handlers necessary? Can you do it yourself, or do you need to involve other person? Do you need to involve other person? And can you access the person in helping? Can you access the person in helping? So these are all the questions, maybe prompt questions you can think, but the tax is basically what you need to do. And then the second one is individual capability. You as a therapist, it's not only about whether you have the strengths or not, but have you been trained and competent to do the tax? What you are probably doing, is it safe? Is it suitable? Do you have a suitable clothing or shoes? Do you have a suitable clothing or shoes to do the tax? And just to diagram mention, sometimes the activities we do, it's important the clothing we do in terms of activity might probably need to be considered. I know now it's good to wear tight tucking and things like that, but there are certain moving and handling that maybe you might want to wear some loose clothing. And in certain climes, they probably wear some loose clothing, polo shirt, all these sort of clothing that will allow you to carry out your functional activity if you involved in supporting the patient. Are you used to the environment? Do you have enough time to do it? So the individual capability, and then the load. So in terms of the load, I will hand it over to the patient, to probably to you to maybe comment. In terms of the load, so think of your patient. If you're going to move a patient, what are those things, both physical and psychological, that you think might influence your ability to move your patient, either strictly for moving and handling or when you are for therapeutic handling of a patient? What are those things so the load is specifically for your patient. What are those things that, in your own view, you think might affect your ability to move your patient or influence your ability to move your patient? Anybody? I will encourage you here to unmute your mic and contribute, but again, you can add. So think of your load. We say the tax is what you need to do. The I is your own capability. So can we have a contribution from people? We can go through the class. Think of your patient. I think everybody can have a contribution here. Everybody is a therapist. Everybody has seen a patient. So I will probably encourage everybody to contribute at this point, whereby the patient you are seeing, the patient you are moving, what do you think will affect your ability to move the patient? So Vera has opened the floor. I would like everyone to contribute, please. So Vera said, if the patient is dependent. Vera, can you expand? What do you mean by if the patient is dependent? You can, please. So if the patient is dependent, absolutely agreed. But can you clarify what do you mean by if the patient is dependent, Vera? Okay. No muscles. Okay. No muscles. Okay. So dependency can be no muscles. So that's physical strength. Okay. That's good point. If the patient is dependent, physical strength. And sometimes, just to add on Vera's point, sometimes your patient can have the physical strength, but they can also be dependent. Like we talked about the confidence, the psychology of it. So it's one thing you want to step away from. Thank you, Vera. Morphology of the patient. So I believe, Quila, when you said morphology, I was talking about the body buildup. How does it influence your handling, if I may ask, Quila? Body buildup. I believe that's what you mean. Oh, Enoch mentioned that the patient is way bigger. So either Enoch or Quila, do you want to add? What do you mean by how does it influence your treatment? I'm still waiting. So can we add? So in terms of your patient handling, what are those things that you think will influence your patient? You can unmute yourself or you can type in the chat box. We all are therapists, competent in our own right. From your day-to-day interaction, what do you think from, or maybe either now thinking backward or going forward, what do you think will influence the handling, how you handle of your patient? You can unmute yourself or you can put it on the chat box. The willingness of the patient, absolutely yes. The willingness of the patient. So yes, thank you. Yep. Uzo mentioned. Okay, probably. So I'm still waiting. So if from your own experience, what do you think are the things from your patient? Inadequate space, yes. So inadequate space will fall under environment, Uzo. So we have tax, but I agreed. Inadequate space will affect your handling. But look at your patient. Okay. So the patient itself, what do you think are the things from within the patient that will affect your handling? Thank you, Judith. Judith mentioned your technique. Technique. So yes, also Judith, absolutely yes. Technique falls under the individual capability, not on the patient. Now, technique absolutely yes will affect that is your own individual. But in terms of the patient, so when you are applying your technique on the patient, what do you think within the patient can influence your handling or therapeutic handling? Yes, agreed. Quila, the morphology falls under the load. Amos mentioned about the size and weight of the patient as well as cognitive state. Agreed. So the cognitive state is where I mentioned about patients who are impulsive or who cannot. Yes. So Quila, yes, morphology falls under weight. Amos, yes. Just a bit more. Still waiting for more contributions. I think we have a lot of people on the platform. Hopefully they are still here. I know it's Saturday. I hope nobody is in somebody's wedding and then joined my meeting. I hope all of us are fully here, and hopefully all of us are here. So still asking the same question. What do you think within the patient? A lot of people have contributed, but just giving space for others that have not contributed. Within the patient's environment, what do you think will contribute, influenced your treatment session? What do you think will influence your treatment session? Okay, for the load, they said almost all. Okay. Environment, space. Okay. Well, thank you. I think there is a lot. You guys mentioned about the size, weight, shape, the pain, the mobility of the patients, the skin condition. So think of the skin condition, the consciousness and unconsciousness. Can they balance or bear weight? So their physical strength, their attachment. So people who have not mentioned. So think of the catheters, the IV lines. These are things that will influence the capability, physical capability of your patient, in ICU particularly, but also in the wards. Then the psychological state. So I categorize it the psychological state, their understanding, and I think a couple of people mentioned fear avoidance, anxiety or fear avoidance, uncooperative nature. So sometimes the way they cooperate, level of and then unpredictability. And then the next one is the environment. Now, people have started already mentioning the environment. So environment is the awkward light space, okay? The awkward tight space rather. So people talk about space. So the space that was contributed earlier falls under the environment. The floor, uneven surfaces, slippery, wet, falls under the environment. The temperature, the lightning, falls under the environment. The obstacles, slopy nature, falls under the environment. So think of your clinic and the environment, like I said. Yes, we are very busy, but it might affect your therapy. So it's something that I want to encourage us to consider it going forward in terms of how does it affect your environment. And thank you so much for your contribution. Thank you so much contribution. Now, the last bit is the equipment that we talked about, equipment. Now, with equipment, I appreciate it might vary from setting to setting, but for equipment is not only the provisions or availability of the equipment, but is the safety checks that you do on those equipment that matters, and whether you are trained to use those equipment or not, and whether you are confident in using those equipment. And if you probably need to, I don't know how many people need to use that equipment as well. So these are all the things that you probably will be looking out for in terms of equipment for the handling of the patient. So in summary, we have TAL. The T stands for task, and the task is what you need to do. The I stands for the individual, and the individual is you, the therapist, your capability. Or it doesn't have to be you, the therapist. It's the individual is about the patient relative or the caregiver. The L stands for the load. The E stands for the environment, and the load, we've talked about it in detail. The environment is the space at which you operate. The O is for others or equipment, and the same applies for the L. So whenever you're doing your risk assessment, or when you're trying to implement either a handling for, put a handling plan in place, these are things that probably you want to look out for. Now let's quickly apply this to, let's say, basic load handling before we move to patient handling. How do we apply this on basic load handling? So if I'm going to do a handling, the first question I will ask is, what is the tax? Now that is our T. What is the tax? Now the tax can be that I am being asked to move the patient bed from one of the cubicles to the ward. That is the tax. Or the tax is I'm being asked, or I am not being asked, if you I want to move a particular piece of equipment from point A to point B. Maybe the TENS machine, I'm moving the TENS machine from the floor, because it's from the floor to one of the plinths, so that I will treat my patient with it. If I am going to move the TENS machine, all these portable TENS or electrotherapy machine or any piece of equipment from the floor to the plinth as my tax, then the second question is the first principle that I need to think of. Do I need to move it? Yes, I have to move it because I want to use it for my patient. Then I need to ask, I have as an individual, so that's where the individual capability comes in. Do I have the ability to move that object? Yes, I have the ability to move the object. Do I have any injury that will prevent me? No. So just ticking those boxes that we talked about as an individual. Yes, you have tick, tick, tick. Yes, I can do that. Then in terms of the load, now the load is the bed, hospital or patient, or TENS machine. Now, for me to move the load, I need to make sure that I know whether the load is secured or not, and I can check it visibly. For me to move the load, I can make sure that it's secured. I can use my legs to just to move. If it's in a box, I can use my hand to shake to open the box to see whether the load is secured. It's important I secured it before I move it from point A to point B. If I'm moving crutches, if the crutches are in a big bowl, I need to secure those crutches so that they are not all over the place. Or if your therapist is moving it, or if your assistant is moving it, to make sure those crutches are secured before they move from place point A to point B. So that is in terms of the load. If it's your patient, then I need to make sure that what is the predictability of nature of my patient? If my patient is unpredictable, then I need to be aware. Is my patient alert and oriented? Does my patient have the ability to understand what I'm saying? What is the consent that is giving it to me? The patient, will it be able to give me consent and things like that? Can the patient use their muscles? And then the E is the environment. I need to see if there is any hazards within my environment. And with the environment specifically, if it is the movement of object and box, you need to think of what is the path from point A to point B. Is it cleared? Is there a sufficient lighting? If it is not just an object, if it's your patient and you are asking them to walk, is there a sufficient lighting that will allow them to move from point A to point B? Environment-wise, what is the temperature? Cold environment, hot environment, do you need to open the windows? Are you all sweating in the place? Do you need to open the window? It might affect the way you treat your patient. It might cause your patient to get exhausted when they are walking. So do you need to open the windows, or do you need to do this rehabilitation or whatever you're doing in the morning rather than in the midday when the sun is very hot? Is there that option? Or do you need to do it later in the evening? And then the O, it stands for equipment. What equipment can come to my aid? What equipment can come to my aid? Now, once I tick those boxes and I'm about to move, let's say the TENS machine from point A to point B, then I will move closer to the object. As we talked about short lever arm, I will make sure that I close my gaps between myself and the object to create that short lever arm. I used my leg muscles if I'm picking up from the floor or supporting from the floor, keeping my spine in a neutral position, and then pick the object, moving close, and then I moved without twisting from point A to point B. So that's basic lifting technique. What if I'm pushing and pulling the loads? Now, if, for example, I am asked to move with you to transfer the bed from point A to point B, or move a load from point A to point B. Maybe let's take, for example, bed transfers, moving beds from one ward to the other. Your therapist or whoever is doing it, when they are moving bed from one point to the other, one is that for bed moving, we have to secure, if there is patient on it, we have to make sure that the patient is predictable, is secured, is able to stay on bed. If there are no patient on it, if it's the bed, if there are two people moving, then the major consideration, apart from us going through the tile or ELIF, the major consideration is the height of the bed. Remember, we talked about trying to use your lower leg muscles or not, adjust the height of the bed. If two people are moving an object and one person is taller than the other, the recommended moving and handling guide is you use the height of the lower person, and so that the object is, the bed is at the waistline, sort of around the waistline of the lower person, rather than increasing it at the height of the taller person. And the reasoning behind it is the shorter person cannot grow tall, but the lower person can adjust their arms in terms of how they support the bed, or they can lower their legs, just as a broad basic principles of moving and handling. Now, talking about our patient, I'm not sure if we can see the picture on the PowerPoint. Can we all see the picture on the PowerPoint? There are several pictures on the PowerPoint. And we sort of name good. Okay. Yep. All right. So I want you, please, to have a look at those pictures. And I want you to tell me what do you think of these techniques. So have a look at those pictures. Let me see if I can put them also in the chat box. And you tell me, what do you think of these techniques? What do you think? First, is it something that you're familiar with? Is it something that has been, and what do you think of these techniques? So that's one of the pictures. Anybody wants to comment on what do you think of this? So that's the picture, all of it in one PowerPoint. What do you think of these techniques? Oops, my PowerPoint has all the information. That's why. Are Are they good techniques in handling generally? What do you think? Is it good for you? Is it good for a patient? Is it good, not good? So do you think it's good for you? For health? Is it good for a patient? Is it good even for the patient relatives? Yeah. So let's start from whether it's good or not. What do you think? Is it good, not good? If it is not good, um, thank you. I can see some comment. So M1 says it's bad for both. I guess the main question is why is it bad for both? M1. So that's the main question. Why is it bad for both? Both for the patient and the therapist, as well as maybe the relatives who are doing that. Why is it bad for both? Okay. Ade always typing. He's mentioning specifically for Biahok. Yes. Anybody wants to comment, please?
Yes, sir, can I talk?
Yes, you can talk. It's open now. It's open floor.
Yes, sir, I think it is bad for the patient because the nature of how they handled him, one, they will drag him over the bed, which most
Okay.
of those, and that alone is a risk for developing pressure ulcer when the thing has become a habit over time. And
Okay.
also where they handled to move him, like holding his shoulder. For example, those stroke patients, they can predispose them to shoulder dislocation. All those patients which have been bedridden and very weak, or the elderly, they can end
Yeah.
up a shoulder. And
Okay.
also the positions they assume
Yeah.
in it's not the best position as described earlier in even in this workshop. Like they are not using the proper technique of lifting. They might be end up posing some kind of mechanical problems to their back. And
Okay.
yes, and I think both of the side are doing the wrong thing, like both on the patient and on themselves.
So you are referring to the drag lift or all of it? So there are different lift techniques here. So are you referring to the drag lift technique?
Yes, sir.
Okay. And that is a fantastic contribution. But the question also, how often do you think this has been done?
So actually, where that has been the tradition even for the nurses, not only the PC, like patient and the relatives used to handle them predominantly in that way. Just hold the patient, drag him up, and just like that.
And why do you think they are doing that? Just to engage you a bit more. Why do you think they are doing that?
Yes, so because likely they think that is the most convenient position to lead the patient for them.
Okay. But have they been given any option or alternative?
Mostly no, sir. It's just like they come to do it and they feel like this is the way to do it, or this is the most convenient way to do it without any kind of specific knowledge of what they are doing or what they are into.
Okay. Believe you me, I will let you go, but if you can. So the last one is, what is the, do you think, what is the alternative, if there is any? Is there
Yeah,
any alternative?
the right alternative, sir, is education.
No,
Proper
so
education.
look at the picture specifically and not necessarily, sorry, what's your name? I can't get your name.
So I am Adam.
Okay, Adamu. So
Yes, sir.
specifically looking at the picture,
Mm.
what do you think, instead of what you've described is absolutely right. Okay. One, you've identified the injuries to the patient and the risks relating to the, depending on the condition of the patient. Secondly, you identified the risks to the individuals. But my question is, if you are, and it is happening not only you as a therapist, but assistants, what do you call them, nurses, family relatives. But the question is, considering that you are in this position, what would you recommend if they want to move this patient in this position? Any idea?
Yes, sir. I will. So even though it's just a kind of a thought, I'm not that much definitive of what to say. I missed some part of the lecture as you are doing it, but that I would say they should distribute the weight over joints, for example, not only the shoulder, maybe shoulder and the lower limb, such that the effect won't be that much pronounced on the shoulder alone to cause injury. maybe they hold the shoulder and the lower limb, and also them too, they should assume a proper lifting position and technique before they leave the patient.
Okay. Okay.
As a whole, not just drag him. No, just distribute the weight, lift him as a whole, and then also maintain a proper technique while lifting it.
Okay. Thank you, Adamu. Please, let's stay on the drag lift. I think it's a good example. We can talk about other options. Can other people, the same thing that Adamu has highlighted, is it, what do other people think? First is, we all agree, well, it depends whether we agree it's bad or not. Secondly, it's, well, we all agree it's not a right technique, but how often is it being practiced in your setting? What are the risks, which Adamu has identified, but you can add? What is the alternative? The floor is open. Anybody wants to comment on the drag lift?
Back to the drag lift. Maybe they can change the bed, the type of bed they are using.
Okay. And what will it do to the moving,
Like
to
the
moving?
kind of one that they can wind to make the patient to prop up. Yeah.
So profiling bed. Sorry, I didn't get your name.
Vera.
Vera. Okay. So you said change the bed. And if they change the bed, that will bring the patients up.
It can help.
Profiling bed. Yes. Okay. What if they want to move the patient up in the bed? Is there any thoughts? Vera?
Not yet.
Okay. But still Vera, maybe how often do you think this is being practiced?
It has been practiced. Yeah, they've been practicing very well.
Have you seen that before?
Yeah, I have.
So the question is, going forward, I think it's maybe start to think of what you could possibly do different, both in terms of you as a person, but also in terms of what you can do within your unit.
All right.
Now, my comment is, if anybody wants to add before we move. So my comment on the drag lift is, yes, it's the most convenient, like Adamu have said. And yes, it probably that's the best thing they know about it. But it's not good for both the patient and the therapist. While we are trying to help, it may cause more injury. In other jurisdictions, this will consider as unsafe practice, and you may be liable if patient is injured. In international practices, this can lead improper handling techniques, not only the drag lifts. Some of those techniques, if they are not, some of them not all. So these techniques are called controversial. Okay, just to highlight, these techniques are called controversial, and controversial because of not that they are not being done. Okay, let's get it straight. These are the techniques that were done many years ago, many years ago. They have even names. So they are being taught, they are being done in practices many years ago. And you will find people, what we call people that have trained many years ago using these techniques if they have not updated their knowledge. But the evidence have shown that rather than helping patients, it is causing more harm to the patient as well as to the therapist. In the morning, I showed evidence of when there are legislations about MSK injury among therapists. When it has been implemented, it reduced the likelihood or risks of injury. So this is why evidence is important. Over time, it has been established that while the intention is to help, but it doesn't. And people are moving away, countries are moving away from using some of those techniques. I appreciate their ability is mainly sometimes use of equipment, and equipment make a big difference in handling. But if you don't have equipment, then it's difficult. Okay, it's difficult. In this drag lift, my older suggestion is, I will talk about the ideal, and then we can talk about the non-ideal. The drag lift technique, the ideal situation will be if the intention is to slide the patient up. So maybe the patient is sliding down and they want to slide the patient all the way back up. There is what we call slide sheets, which we will consider. and they will put the slide sheet under the patient. And there are a process or techniques of putting those slide sheets whereby you don't have to drag or the patient. You just roll the patient from side and then put the slide sheet and roll them back and use the slide sheet, which are slippery, and then use the slide sheet, sliding them all the way up. Now, using the slide sheet will reduce the risk of friction because you are putting a sheet underneath the patient. So those sheets are facing each other, and then you slide one sheet over the top of the other. So it reduces the risk of the injury on the patient and you don't drag the patient. However, the use of slide sheet or equipment alone doesn't take away the risks to you as the therapist or to the family. Now, this is where your techniques or your training comes into play. And I think some of you have mentioned. So talking about all the principles we've talked about, if you are using a slide sheet, you have to make sure that the bed height is appropriate. If it is not a profiling bed or bed that changes height, then you have to bend you have to bend from the legs and the hip rather than from your waist when you are holding those slide sheets. And you don't bend over the patient, you take a natural spine posture, and then you slide, because if it's a two-man lift, two people lifting, one person on the left, one person on the right, you have to communicate and slide at the same time, going up or going down. How you place your hand using the slide sheet is also important. I think I mentioned about weight distribution. The recommendation is you hold, so think of where your weight is heavily distributed is the pelvic region, as well as the pelvic girdle, the pelvic girdle and the pectoral girdle. One of your hand will hold the slide sheet on the pelvic girdle, the other hand will hold the slide sheet on the pectoral girdle, and both of you will slide from the pelvic and the pectoral girdle sliding up. Now you have automatically take the most part of the weight and you're sliding them all the way up. So that's hand placements when you are using that. The second one is your movement. We said, if you remembered in the morning, we said have a dynamic base of support. Have a dynamic base of support. So when you are sliding this sheet, the patient is moving all the way up or down. If you do not move, you will be stretching yourself or you may be twisting yourself. It depends on how you position yourself. There are two ways you can do that. One is you can face each other while you are holding the slide sheet and you take a lateral step. So you take a sideways steps at a rhythm, at a go. Ready, steady, slide. So you take a step side to the direction at which you are moving. That is one way. The second way is if you are not going to take a step, you probably want to point your legs in the direction of the movement so that you are not twisting. So you point your leg in the direction of the movement and then you rock, you do a rocking movement. You have a wide base stance and you do a rocking movement. So you rock from where you are starting position towards the direction you are going. And then that takes away the fact of all those twisting, burning. And then that also protects you. Now, this is ideal situation. And like Vera said, you can have a profiling bed where you bring the head up and then you position them. And then once you bring the head up, you can then support the patient from behind and then lower it and put the pillows. But that is ideal situation. That is ideal situation. And of course, I mentioned in the use of patient's effort, because what I can see here is that the patient is lying loosely. Now, it is possible our patients do not have the effort at all to do things. And this is where the use of equipment also comes in. If the patient doesn't have effort at all to do things, then you might think of even not the slide sheet, even use of hoist, which we'll look at it later on. But if the patient has some ability, I would have encouraged the patient to bend their knees, looking at the drag slide. I'm talking about the drag lift. Patient can bend their knees and push themselves backward. And this is why you encourage them. They might not do it first time, maybe in your rehab, you can just ask them to just bend their knee like you're going to do bridging, not necessarily doing bridging. And then they will use their muscle strength and push themselves backward. That's the example. But that's ideal. What if you don't have slide sheets, if you don't have all those things? If you don't have it, I think you probably will have, think of, in place of slide sheet, you can use the bed sheets, but it's not encouraged. Standard practice, don't use the bed sheet to drag. But if you don't have slide sheets, think of the weight distribution. One, instead of dragging the patient at their shoulder, you can use the bed sheet holding one at the pelvic, the other one in the pectoral girdle. If you have two people, you now move the patients up. However, if the patient can't be able to move, have any strength, I will encourage you to ask the patient to bend their feet and then push backwards and keep encouraging them. You can even, if you can help them by planting their feet on the bed while they push themselves backward. And they don't have to push all at once. They can shuffle themselves backward. That is probably what I would say. I will recommend, or I would say. And I see there are lots of comments. Yes, Vera mentioned slide sheet. Yes, it's the same as draw sheets. There are different terminology, but I'm not sure. It depends. So any slippery, so slide sheets, draw sheet. All I'm saying is any slippery sheets that you can use. Usually the slippery part is not on the patient. The most slippery part turn on each other. So you can have two pieces of sheet and one on top of the other, and they will be sliding. So that's the slide sheet, or you can have a tubular sheet where they are slippery, they turn on each other. So yes, that's it. And now going forward, so that's just the drag lift. What of the other bit? I think they are all sort of speaking from the same bit. The Australian lift, the orthodox lift, the true arm lift, and all other sort of lifting. They all also speaks almost the same bit. But I will go back to the chart. Let's see. I think there is some comment people made. So Bear Hawk is good. Okay. Adewale mentioned about Bear Hawk. Let's take Bear Hawk. Bear Hawk is the next one. Bear Hawk or pivot transfer is good. Okay. Bear Hawk is good, but leads to back pain if the patient is overweight. Okay. So Adewale, if you don't mind, in terms of Bear Hawk, well, what type of if the patient is overweight? In terms of Bear Hawk, is there any better options apart from Bear Hawk? Is there any? I know we can use Bear Hawk in our settings in terms of, like I said, these are controversial techniques. It depends on the jurisdiction and it depends on the situation you find yourself. But let's say Bear Hawk is good. But apart from Bear Hawk, let's say is there any other options apart from Bear Hawk, Adewale? Or is it Temitope Adewale? If you don't mind, do you want to expand on? Do you think is there any other options apart from Bear Hawk? In terms of if you want to do Bear Hawk or want to improve on Bear Hawk technique? Yep. Okay. Brilliant. Thank you. So you've heard of Sarah Steady used instead. Okay. Thank you. Adewale, okay. What do other people think of Bear Hawk technique? Okay, Amos is typing. What do other people think of Bear Hawk technique? So you mentioned about the likelihood if the patient is too big, so that is the load. What are the risks involved in Bear Hawk? So I want you to identify what are the risks involved in Bear Hawk, the same as we've done for drag lift. How often is Bear Hawk being practiced in your setting? What are the risks? Are there other options? Yes, what are the risks in Bear Hawk? So as a therapist, and what sort of patient profile will you be using Bear Hawk for them? mostly for neuro patient. Okay, bear hug is practiced more often. Okay. And what are the risks involved in bear hug? So just for us to identify the risks when you're doing this. And when you're doing it, is it for all stroke patient or some stroke patient? Yep, falls in case of bigger patient. Yep, the load. Slipped discs. Okay. So yes, thank you. So in terms of bear hug, I agreed. Bear hug is still controversial technique in some jurisdiction. It's been used often, but the risks are, apart from what other people mentioned in the chat, it also includes the patient can, especially the idea of bear hug is you are stabilizing the weak leg and you are moving the patient. The patient legs can buckle and then they can fall. They can drag you. So where possible, it's just a question of if you are doing this over and over and over again, how long will you be able to carry on doing this? Certainly, if you are a young person in the profession, you probably will be able to do bear hug. But I will imagine elderly people that have been in for a very long time will struggle to do bear hug technique for the patient. So sometimes the recommended practice is to make sure that there is that consistency of care. And there are histories of patient falling when doing bear hug, especially when you are not very skilled in doing it or supporting the patient appropriately. And the options usually is the use of equipment. So you can use bear hug for transfers from bed to chair. But also, I think we therapists use this for their rehabilitation as well. But it's the use of equipment. And one of the equipment was mentioned is Serra Steady, but there are other ones, Return, if the patient can do that. Another option is, depending on the level of the patient in transferring, there are different equipment that you can do for patient. What of the arm and leg hug or the hammock transfers? So the two people trying to take one person from the bed to the wheelchair. One holding their upper body, the other holding their leg. What do you think of the other one before we come back to the chat? So what do you think of the arm and leg hug or hammock transfers? And please, I will encourage you to unmute yourself. We're almost going to the break time. I've noticed, is it 12:40 now? Or maybe not, we still have a bit of time. So the arm and leg hug or hammock transfers, what do people think of it? Okay. It can cause discomfort in the axilla. Okay. The hand of the person holding the leg supposed to be on the knee. Okay. I'm still listening. Anybody wants to add? Thank you. It won't be good for patient with spinal problems. Okay. So the question is there a better option? Irrespective, so yes, we identify the risks, we figure out what we could do to improve. But is there any better option of using this instead of one person dragging the person from the top and then the other one on the leg? Is there any better option? Anybody wants to, any better option? Before we move on, any better option? Okay, somebody recommended use of slide sheet. So, okay. So we are transferring, okay, but it's just, I'm trying to wrap my head. We are transferring to in a wheelchair. So looking at that, okay, but that's fine. I will comment about the use of the slide sheet. Thank you, AE, for the suggestion. Any other better options? Or maybe AE, do you want to expand on how will you use slide sheet in this situation? Maybe just to give my understanding, how will you use slide sheet in this situation? Anybody? Okay, Enoch mentioned about transfer belts. So, that's interesting as well. So also Enoch, how will you use transfer belt in this situation? Because I'm thinking, where will you put the belt? Where will one person stand? How will you use transfer belt in this situation? Okay, that's a good point. Vera is typing. So if the patient is not dependent, you can assist rather than two-person carrying. Okay, so that's good thinking. So that's first is yes. Can you engage the person muscles? You can assist rather than carrying. So maybe starting from the point Vera raised, how can you assist the person in this situation to transfer from the bed into the wheelchair? Vera, if you don't mind, you can speak. Vera, or I think speaking will be much easier than typing. If you don't mind, or you can type. How will you assist the person to transfer from the chair from the bed to the wheelchair? Let's say he is not sort of dependent.
Okay. They will have to be in a sitting position. You transfer the
Okay.
patient to a sitting position on the bed.
Okay. Yep.
Okay. Yeah. Then with both persons trying to stand the patient, I know the wheelchair is already locked. Okay. So the person, both of them are trying to assist the person, and the person is already up. Thereby, you turn the patient can easily sit on the wheelchair.
Okay. And why would the both person be standing? Why will the first person standing? Why will the other person be standing?
Beside the patient.
Okay.
They can stand beside the patient.
Okay.
Yeah.
Thank you. Yeah. Thank you. So I agree with you in terms of the transfer from the bed to the wheelchair. If the patient is able, we reposition the patient in sitting position. However, before you transfer him to or her to the wheelchair, you want to put the wheelchair as close as possible, while and then it at an angle preferably. And some wheelchairs have removable arm where you can remove the arm close to the bed. For the patient, before you transfer the patient, you need to position their feet in the direction of travel. You need to position the patient's feet in the direction of travel. So if they are going, you position their feet in the direction of travel. And you need to use the same principle we talked about, whereby tilting the patient forward, displacing their center of gravity forward, so that to give them that advantage when they want to move. Now, it depends on their dependence, or depends on the level of their strength. If the patients have sort of upper limb strength, I will ask them to use their hand that is closer to the wheelchair to reach out to the wheelchair. So automatically they have reached out to the wheelchair, and then they can just do what you call just sort of like, it's not a pivot transfer or bear hug transfer, but they will just transfer from the to transfer from the bed, whilst I support them around their pelvic region. If there are two people doing it, the first person will stand in front of them, the other person will stand behind them, and then I will be repositioning their feet. The second person behind them will support their upper body or pelvis in the direction. So you are not moving them, but they are doing the movement, but you are guiding the movement in the direction of travel. That is if they are able. Now, if they are not able, then the amount of effort you give them increases. Also, in ideal situation, if they are not able, you can think of using sliding board or banana board as we call it. Now with banana board, if it's the patient cannot be able to transfer, the same repositioning the patient in the bed, you put the frame at an angle, you ask the patient to turn opposite to the direction they are traveling, and you put the banana board underneath one of their arms, that is one of their legs, that is closer to the wheelchair. And you ask the patient to slide on the banana board, which requires less effort from the patient. Even if the patient cannot slide at one big swoop, I will be standing in front and the other one behind. If the patient have poor sitting balance, I will require two people. And then we can decide to do two or three movements. First is the patient to slide into the banana board and keep on sliding until they slide all the way into the chair. When they are using banana board, I need to be aware of their hand placements, their foot placements, the same foot placement in the direction of the travel. Hand placement is preferably on the opposite arm of the frame to make sure that their hand is not stuck under the banana board, and then they will slide into. I will be guiding them around their pelvis and maybe upper region, and then the legs will be in the direction of travel. If the patient is also not able to do that, then there are other levels of transfers that includes, in an ideal standard practice, is the use of other equipment such as Serra Steady or return. If the patient will stand up and then you turn it all the way around, which will look at that. Or if they are still not able to do that, probably like in this picture, whereby they are totally dependent and is the use of hoist, which I think is a luxury in most settings. But that will be my thought processes around the arm or leg hug transfer. Any question? Let me come back to the chat function. Anybody has any questions so far, or anybody wants to comment on the pictures on the slide, please? Okay. Wherever possible, intervention should involve minimal lifting and safer handling. Wherever possible, minimal lifting and safer handling. And if you are thinking of the therapeutic, whatever, we need to think of the aims, the movement and handling needs should be considered to maximize potential. I think somebody mentioned about handling belt. For handling belt, you can use handling belt in this situation. The handling belt will go around the patient waist, but you are using the handling belt as a guide. So remember I mentioned earlier, I am using my hand to guide the patient. So I can use my hand and use the handling belt not to drag the patient, but to guide the patient when they are transferring, either with the sliding board or without the sliding board if they are using transferring from the chair, from the bed to the chair. Thank you so much for the contribution. I'm mindful is 12:50 now in Nigeria. Is it okay if we, I know lunch is almost close by, but I want us to, when we go for a lunch, we go for a break so that I'm not sure what time is the prayer time, so that we can come back. All of us can go and then come back. So probably I will carry it on if it's okay. In the next around 1-ish.
1 to 2 is the normal. Yeah.
Okay, 1 to 2 is the prayer time.
Yeah, so literally like 1 hour 10 minutes from now. That duration, that the duration between 1 hour 2 minutes, like everyone should be able to pray.
Yeah. So what I mean is that okay, I understand what you're saying. Okay, so let's continue before. So let's take another. If we break around in the next 30 minutes, would that still be okay? Is that Adamu?
Yes, sir. If 1 hour is not too much, 1 hour will be perfect for everyone. Some used to pray around 12:30. 12:50. Some used to pray around 2.
Okay, let me take this one more slide before I go then.
Okay, sir.
So transferring patient. We talked about transferring patients. We talked about transferring patients. So we looked at different handling techniques. Like I said, by all means, these are controversial techniques. Jurisdiction varies. Sometimes I appreciate how much the lack of equipment can make us be creative in our own way. But whatever you're doing, try to minimize the risks of injury to yourself and the patient. I mean, use the patient, leverage on the patient muscles, rather than you doing it yourself. How you choose to transfer patient will depend on their physical ability and mental capability, which we talked about. Yeah, your own confidence in terms of the skills you have or the training you have on handling those patients, and your experience. Sometimes some of those things come with experience, and the equipment available. I think the equipment is something that we will all agree that it's not is a luxury in most settings. But in terms of as a physiotherapist, we can certainly be able to assess our patient's physical and cognitive ability before. And then we can be able to, we know within our own scope of practice whether we are skilled enough or confident enough. And there's no if you don't have the confidence or competence to do it, by all means I will recommend you speak to your colleagues. I will recommend you do some training, in-service training within your settings. And certainly it's good that you are attending today's sessions and take away something today and go and put it in your own setting. So I mentioned what you assess before carrying out transfers. There are different things. The question is, are they medically stable? So apart from their physical strength, are they medically stable? You may need to, now it depends, you may need to discuss with the nursing and medical team or not, or you can just check the observation. I believe it's something we do every day, but just to highlight that you probably want to check the patient observations, not necessarily you doing it, but you can check the chart. Sometimes if they're in the ward, you will have the nursing chart, because you don't want to start transferring person and then there will be a sudden drop in blood pressure, and then they fall. So these are things you want to look out for, or you want to worsen their condition. Can they follow instructions? So when you are checking them, can they follow instruction? If they may not be able to be steady once they stood up and walk, can they be able to stand up and walk? Can they follow instructions? If they cannot follow instruction, you don't want to be dragging patients. You want to communicate and engage with the patient. It might be your communication strategies. You want to change it. It might be you want to speak to their relatives. So one thing I find is some patients have, when they come to our settings, they have had a way of communicating even before they come. So speak to their relatives, speak to their spouses, carers. They may give you the clue. They may give you the tips on how you can being able to support them to follow instructions. Do they have the adequate leg strength to stand up? Do they have the adequate leg strength to stand up? Without it, they may be at significant risk of fall. And maybe I will ask, in terms of leg strength to stand up, now there is no recommended whatever it is, but just as clinicians, when you are trying to stand patients on their feet, looking at the Oxford Muscle Grading Scale or manual muscle testing, what sort of level of muscle strength or grading do you check, or it makes you feel confident in terms of to put patients to allow patients to stand on their feet or bear weights on their feet with sort of less support? Okay, somebody have put in Demola. So what level of muscle strength do you want to check before you put the patient standing on their feet? Can we all, I think we are all therapists, and I believe we've assessed. So what level of muscle strength? I want you please to put in, we are almost there to stand on their feet. I can see some chat. I can see different numbers. Keep them coming. Muscle power, yeah. What level of muscle strength? I can see 3, I can see 4. What muscle strength do you usually consider before you put them on their feet? Okay, so I can see 3, I can see 4. So my question is, if they are not level muscle strength level 3, I will go, okay. Is that 5 I'm seeing? Maybe not. If they are not level muscles, so level 3 means they can move against gravity. Yes, there will be some buckling and things like that. But if they are not able to get muscle strength level 3, will you still, now you need that anyway to stand, but there are things that you need to do to support them and things. But if they are not level muscle strength level 3, will you still be able to stand your patient? That would be my question. And please, I would appreciate if you unmute yourself and expand on that. If they are not level muscle strength 3, I think I will still go with most people. Level strength 3 is sort of around that area that we should be thinking. But if they are not, will you be able to stand them? Okay, I can see most people are saying yes. Okay, they are saying, talking about autosis, back slap, and things like that. Okay. So maybe my next question, thank you all. If you use those autosis, I think most people are mentioning about a rigid autosis around the knees, and especially when you use back slap. If you use those autosis, are you engaging the muscles around the knee more if you use those autosis, or not? Or is there any other options of how to? But the obvious question is, I feel if you use those, while it's good, brilliant to use them, but if you are thinking of your therapy, you are less likely to engage to the patients to problem solve. So they need to figure out in terms of engaging the muscle control around the knee. If you use those autosis, it will restrict their ability to use that. And by all means, I would say use it because there are reasons why you should use it. But also think of rehabilitation wise. How can you engage the leg muscles? Okay. How I would possibly think of that is, I will use, if where possible, I use equipment in terms of their standing without necessarily the autosis, but I will certainly need extra supports, but I will support the knee and trying to reduce the amount of supports I give the knee and encouraging the patient trying to control the muscles around the leg and stand on their leg. Well, it depends on what I want to achieve. If it's just standing, you might, for a long time, you might want to use the autosis, but if you want to control of the muscles around the knee, you might want to reduce that autosis. But yes, orthosis is a good example. But it's less practice in other jurisdiction. But yes, orthosis is back slap in particular. The other bit is now level 3. It depends on the height of the bed or the height at which your patient is transferring. There is what they call perch attempted standing. If you increase the bed height, or if the patient is standing from a very tall position, they can try to stand up and recruit from a higher level if it is 3 minus or 2 plus. So this level at which you are encouraging them to engage with their sort of knee muscles. But your contribution, I agree with it. Absolutely, yes. But apart from the lower muscle strength, do they have adequate arm strength? Okay. When you are transferring, do they have adequate arm strength to push up from the chair? So engage or ask the patient to push up from the chair when they are transferring, or hold on to their walking aids. Do they have vision or hearing? Do they need 2 glasses? The example I've given is patients that have impaired vision. So the question is, do they have impaired vision, or do they need their glasses? All these things are important when you are carrying out your transfers. And it is just after 1 o'clock. I will probably pause here, and then when we come back from break, we will start to look at patient handling. We'll look at bed maneuvers, sit-to-seat maneuvers, standing, walking, all those things. We'll start to look at them, applying everything we discussed. We will come back by 2 o'clock. Okay. It depends on which country you are joining us. You come back by 1 o'clock or 2 o'clock. Okay. Let's go for a break and come back by 2 o'clock, please.
Okay.